We are live now, ma'am.
Yes, go ahead, please.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Amogs Emergency Obstetric Committee with Rewa, Ratlam, Ujjain, Narmadapuram, Gwalior Societies of Ampox. Let me introduce the MOCs of today's webinar, Dr. Dolly Mehra ma'am. Ma'am is a consultant obstetrician and gynecologist at Mehra Nursing Home, Ratlam, and also president of Ratlam OBGY Society from 2014 to 2019, and also joint secretary of AMPOX in 2019, faculty at various national and state conferences. I welcome you, ma'am. And it's my honor to introduce Dr. Brajbala Tiwari, ma'am. Ma'am is the consultant gynecologist and infertility specialist, and also managing director of Life Care Hospital Limited and the Santati Infertility and Test Tube Baby Center. Ma'am has been the president of Indore OBGY Society from 2022 to 23, vice president of Indore Menopause Chapter, past vice president of IMA, and ma'am has so many awards to her credit. I welcome you, ma'am, and I hand over the session to coordinators.
Thank you. Good afternoon, respected guests, honorable faculty members and delegates for this important Amogs AMPOX webinar. With blessings of our seniors, Dr. Kiran Kulkrati, President Amogs, Dr. Vipin Pandit, Dr. Parag Biniwale, Dr. Rajendra Pardesai, Padma Shri Dr. Leela Joshi Madam, Dr. Kavita Bindal Madam, Dr. Archana Base, we are gathered here to discuss important topics in emergency obstetrics, which is useful for us in our day-to-day practice. So I call upon Sneha Bhuyar Madam, Chairperson of Amogs Emergency Obstetric Committee 2024-2025 to welcome our guest. Can I have the CV of Dr. Sneha, please? Dr. Sneha, she is a very hardworking, very dedicated Foxian and is a candidate for our elections Foxy Vice President election West Zone. She has been the Foxy Breast Committee Chairperson 2019-21, GCM ICOG 2021-2022, National Adolescent Trainer WHO Certified, National Expert UNICEF, Peer Reviewer of Jogi, Amogs Chairperson Medical Disorder Committee, Amogs Chairperson Emergency Obstetric. Under her leadership that we are organizing this webinar. She is also a CEFOG working group member on breastfeeding, founder president of ISOPAR Vidarbh chapter, president of Yorks 2007-2008, and founder clinical secretary of Yorks 2003. Life member of Foxy, IMA, ISAR, IAG, IMS, ISOPAR, and she has so many awards to her credit. I welcome you, Dr. Sneha, and please, I request you to welcome our guest.
Thank you so much, Dolly. But before that, I would just like to have the blessings of God Almighty, and may I request Sahiti to please play the inauguration video first.
Okay.
Ankurutvam kalyanam arogyam dhanasampadam Shubham kurutvam kalyanam arogyam dhanasampadam Shatrubuddhi vinashaya Deepajyotir namostute Deepajyotir namostute Shubham kurutvam kalyanam arogyam dhanasampadam Shubham kurutvam kalyanam arogyam.
So, with the blessings of God Almighty, and let us have the blessings of seniors as well. So, thank you so much, Dolly, for that kind introduction. But apart from my national and international awards, I would like to introduce myself as a hardcore practicing obstetrician and, of course, a common Foxy member. I would like to welcome one and all Respected seniors and dear friends, it's indeed a pleasure to welcome all of you for this virtual academic session of Amogs Emergency Obstetrics Committee with Ratlam, Rewa, Ujjain Societies of Amogs. And of course, we do have our friends from Narmadapuram and Gwalior Societies. So at the outset, I would like to express my gratitude towards both the organizations, Amogs and Ambogs, for the opportunity to collaborate, especially President Dr. Kiran Kurtakoti, Secretary Dr. Bipin Pandit, Dr. Parag Biniwale, our National Coordinator, and a dear friend, Dr. Rajendra Singh Pardesi, the immediate past President, and from Amogs side, Dr. Kavita Singh, Madam, the President of Amogs, and Secretary Dr. Dipti Gupta, and of course, immediate past President, Madam Jyoti Bindal. Always very inspiring and blessing, Madam Leela Joshi, Dr. Archana Basev, whom we are fortunate enough to have our guest for today's program. Of course, I would like to have the blessings and guidance from all of you. I also welcome the Amogs. I also welcome the faculties for today's program. All the chairpersons, I can see Dr. Pam and Shikha, and of course Shefali. I welcome all of you, all my panelists, Dr. Sunita, Mudita, Varsha, Neha, Shikha, and of course Dipti, our vibrant secretary of Amogs. I welcome the speakers for today's, as I have to talk about this program, why we selected these topics, because we always focus on reducing the maternal as well as perinatal, not only the mortality, but also reduction in the morbidity. And that is why we have selected this topic of sudden obstetric scholar by none other than Dr. Geeta Balsarkar, and of course, Madam Pushpa Zungare Somonshi, who will be speaking on the fetal surveillance. So I'm sure this program is going to be very helpful for all the attendees as well. And once again, I welcome all of you. And I would like to take the blessings of our seniors now. And may I have the CV of Madam Leela Joshi first. Madam is Padma Shri and Padma Shri awardee, and of course a very, very inspiring personality, though a very grassroots level worker. At this age also, she has still continued her social service. So Madam is actually the retired Chief Medical Director of the Indian Railways and senior consultant from Ratlam. Without wasting much time, I think, Madam, we would like to listen to your precious words of blessings. So over to you, Madam, for your blessings.
Thank you so much, Sneha, for very, very kind introduction. Today's guest, whether I don't know whether Dr. Jyoti Bindal is present here or not.
Yes, ma'am.
She's present.
Ma'am is there.
Okay. And Dr. Kavita Singh is probably busy. That's what they were announcing.
She's also
there.
I'm there,
Yes.
Madam. Namaskar.
Oh, nice. And Dr. Archana, and from Amogs. I'm very happy to see Dr. Parag Pinawala here. Welcome, Dr. Parag. And all the Amogs members, the president, Dr. Kiran, Dr. Pandit, Dr. Pardeshi, and all the chairpersons and Madhuri and Sneha. And all the chairpersons, speakers, panelists. I must say that you have chosen a very, very important subject. The way we are facing almost every day such problems. And I am very sure that we'll get a good message, good information, good this thing, so that we can manage our patients better and we'll become wiser. I am so very sure that after this webinar, I won't take much time. My all the best wishes to all, one and all, Dr. Brijbala, Dr. Sneha. I must say, I am very much thankful to you that you make me a part of this, a very, very important webinar which we are going to have today. My all the blessings, best wishes, and everything nice for all of my friends of Foxy. Thank you so much.
Thank you, madam. May I have the CV of Madam Jyoti Bindal? Uh, I don't think anybody needs this introduction. Madam is such a well-known personality and, of course, a great inspiration to entire, not only Amogs, but I would say the whole India. Madam is at present the Vice Chancellor, of course, the immediate past president of Amogs, and she has lots and lots of major achievements and association. All of you know it is displayed here, but above all, I would say Madam is a very inspiring personality, working from the grassroots to the policy making, and of course, lots to learn from you, Madam. Over to you for your precious words, Madam.
Thank you so much, Sneha, for having me here. Brijbala and you together have put up such a brilliant program, and I'm so happy to be a part of it. I'm not going to name all the people we are sharing the platform with, but definitely it's an honor always to be in presence of Dr. Leela Joshi and Parag. It's always a pleasure to be with you. And I'm not naming individual. Kavita is such a brilliant successor and she's going to turn around Amogs. I'm so happy to be here. Dolly, you called us, Dolly ne pata kya kiya? Hum dono ko join kar diya. She called us Kavita Bindal. So that was great.
I'm so sorry, ma'am.
I will not go into the, as I said, you've already introduced all the speakers, chairpersons, panelists, and you've really chosen well, Sneha. COVID times had introduced us to this webinar culture, and we all are finding it very, very convenient. People like me who hate to travel, I think for us, it's actually a boon. My only request to all those present here is that somehow after the session, we should have the recordings available, because many of us can now then listen to the inputs, and trust me, no age is more for learning. I mean, recently I attended a CMA with Dr. Bhaskar Pal speaking about how to deal with the complications during cesareans. And मुझे याद ही नहीं पड़ता, in our times, the record keeping was not so great. I cannot recollect how many thousands of cesareans I must have done, but yet there were so many new points I could see. So what I'm trying to say is that one, we should all make, because it's not that, the more knowledge you give, the more knowledge you gain. One more thing I wanted to add, Sneha, and maybe Parag, you may not know, but people of Madhya Pradesh at least should know something which really, really shocked me 3 days back. Madhya Pradesh holds the honor of number 2 highest maternal mortality state. We are second only to Assam. This is such a shameful figure, Kavita. We really need to do something about this. And so the sudden obstetric collapse, near-miss situations, fetal surveillance, we are number 1 highest in neonatal mortality rate. I mean, look at us. So this is really something which should make all of us awake and, work on it. So medical disorders of pregnancy, PIH is really, I was just reviewing the deaths in the institution where I'm working, and I was looking that I was just looking at January deaths, and we had 3 cases, all of them referred, even today's world, they were referred from remote. 2 of them had intrauterine fetal death. One was with septic shock. One was with eclampsia. Eclampsia patient coming to Indore today, in today's world, it's something, our remote system has to be made robust. And that's why, Sneha, I think the conveying of this webinar needs to be all over the country. And Parag, I think maybe, you should be doing something about it, maybe more of YouTube videos, something we need to do that this webinar, whatever topics are there, brilliant topics. So I'm myself going to be, looking, hearing all this, but har baar nahi hota, odd times mein hota hai, koi webinar, so somewhere we should all have the access to this. Thank you so much.
Thank you, madam. Thank you so much. In fact, your suggestion is well taken, but for your information, after every program, I'm posting the recording. Saiti is very kind enough to, share the recording immediately after the program, and we have been doing that. So
But
thank
you're
you.
posting it in your group, on your platform.
Yes.
I'm asking it to make
it is on the YouTube. It is available on the YouTube, madam.
Yeah, I think we should, what Dr. Jyoti Bindal is saying is very, very valid. We should put it on the Amogs website so that
I
people
think so.
can
Yeah,
access
we
it
will
and we
do
can
Yes.
just circulate
Or
it.
maybe, ICOG can put us.
ICOG, Dr.
For
Jyoti, all the
Foxy,
programs
ICOG
which
is
we are
doing
doing in
that.
ICOG are there on ICOG
But
website.
ICOG is Indian college. So you are responsible for the whole country. So whatever any society is doing, I'm asking you this. Let's have it with ICOG. Maybe
Sure,
something.
sure. It is, Dr. Jyoti, it is very much there on
Yes.
ICOG website. All the programs, right from COVID times, all the webinars which have been conducted under the
By
ICOG are
ICOG, under ICOG banner. What I'm
sure,
asking
and
is,
we'll be happy to share
let's
it
have
with Kavita for
MPOG
Ampog's
programs,
website
Amogs
also.
program, whatever society does.
Sure, we will.
Thank you so much, madam. And I'm happy to share with you that last month only we have had such program with the Northeast societies. And, we were amazed to look at the figures, and these people were so happy to discuss all. We had very good speakers for postpartum hemorrhage, the operative procedures and, uterus conservative, and of course, how to reduce maternal mortality with postpartum hemorrhage. All these problems were discussed, and I had moderated the panel discussion on the near miss case scenarios. So it was very much appreciated, and all the recordings definitely I will try to share with you, maybe personally also. So
Yes.
thank you so much, madam. And thank you so much, Parag, for adding your opinion, also valuable for all of us. So now I request Dr. Brijbala to introduce Madam Kavita Singh and have her precious words.
Thank you so much. Good evening, Dr. Parag sir, Dr. Jyoti Mindal madam, Dr. Leela Joshi madam, and all the faculties. It's my humble privilege to introduce none other than my dear friend with whom I am associated since last 4 decades from MBBS first year only. So it's a great to say something about Kavita. Not only she is professor and HOD of Medical College, Bhopal, Dean now, and she is the first in all who had PhD in this, and she had been associated with Tata Memorial and New York Cancer Association, WHO, SARO, trainer colposcopy. She is having so much experience as now currently she is leading AMPOG, and the way she started leading AMPOG is commendable, and she is really succeeding Jyoti Bindal madam in very great way. So she had been president MPSC. Also, she had been president Jabalpur Society. She is coordinator of Medical Education Unit and member Ethical Committee MP, Medical University Jabalpur MP State, and so many. She had been awarded Foxy Durusha Community Service Award, and she is doing a lot of community service with her students. I have seen her pictures. For a week she is staying in remote area for really serving those who need for this thing. So with this, I welcome Dr. Kavita for your blessings.
Sorry, I'm interrupting. One line Kavita has not mentioned. She's a governing council member, and Jyoti ji, Kavita can be the liaison person with ICOG. She's my governing council member this year and next. Kavita.
Yeah. Thank you, Bridge, for lovely, kind words. Only which was sensing a little moment and sentiments of pride, which can come from a classmate only. So I'm equally proud of you, dear. My humble regards to Dr. Leela Joshi, madam, Dr. Jyoti Bindal, madam, And thank you, Dolly. You have added my energy by saying Kavita Bindal. You know, एक पे 11 हो गए हम लोग, हाँ? Because मैडम को देख के मुझे एनर्जी आती है. And on a seat of Dean GMC भोपाल, अगर मैं मतलब जब मुझे लो फील होता है, then I मन में जिनको कुछ लोगों को याद करती हूँ और सोचती हूँ जिन्होंने बहुत सक्सेसफुली ये सब काम किए हैं. So madam is one of them. And so, madam, my regards to you, and thank you, Sneha, Dr. Shashibala, Dr. Rekha, Sunita, Dr. Geeta. We are making you wait, but this is how the Mpox and Amogs is. So, just few more minutes from our side. Yes, Madam Bindal has rightly said that it is high time for us to strengthen our associations as well as our commitment for maternal and child health. We are trying our best, but everything is surfacing only. We have to go to the grassroots level. And I'm looking forward not only ICOG, but also Foxy's and all the teaching institutes and the friends working wherever they are working, that we should strengthen our HRP detection and, the ASHA and ANMs, because majority of the deaths are due to HDP and anemia. And both of them can be picked up by an excellent antenatal care. So maybe not in the first trimester, at least in the second half of pregnancy, when the medical disorders peep in and there is, all the problems, they keep on arising. So that is the time we should emphasize after mid trimester. So this is what I just want to add on. We are trying our best, but there's a lot to be done. I'll be appreciating if you can involve our health policy makers also, those who are looking into, because nowadays medical education is Lok Swasth and Chikitsa Siksha. Means we are having our public health associates also, those who are working. So everyone is accountable, including me, including all of you. So let us do whatever we can do at our places wherever we are working. I wish good luck to this program, and my congratulations to all the organizers, and thank you for inviting me as a chief guest. I'm so humbled and thankful. I was in a meeting. I traveled while I'm back to my office. I was listening to Madam Leela Joshi and Dr. Bindal also. So my regards to everyone. Thank you. All the best. Thank you.
Thank you so much, Madam Kavita Bindal, for your precious words. Of course, whatever message you have delivered.
आपने तो हमारा नाम ही रख दिया, हाँ?
Sorry, I think it goes on, blindly following that indicates. So, Madam Kavita Singh, thank you so much for your precious words. And definitely, I think as we always say, that we have to work at 3-tier system. Even as committee chairperson, we have done that. So definitely, general public awareness and involvement and training of the paramedics, and of course, our role as healthcare providers definitely should improve. And that is why I would say the sensitizing the obstetrician with the active involvement will be from our side, and it's going to help us in long way. So without much ado, I would like to hand over this to Dr. Dolly for introduction of Dr. Archana Basir. So has Dr. Archana, I can see Dr. Archana joining, but yes, yeah, welcome Dr. Archana. And
thank you, Dr. Sneha. Thank you.
Sorry to introduce Dr. Archana Basir.
So it's a great pleasure to introduce and welcome Dr. Archana Basir, Madam. She is Foxy Vice President 2020, Organizing Secretary AICOG Indore 2022. She is past fellow representative of AICC RCOG West Zone. She is Imaging Science Committee of CEFOG, AFOG, a member, and she has been chairperson of the Foxy Imaging Science Committee 2015 to 2017, Organizing Secretary ISAR 2016, Managing Committee member of ISAR, IAG, and ICOG. She's also a Guinness World Record holder to remove the largest uterine tumor. Welcome, Archana Basir, Madam, and we would like to have your blessings.
Thank you, Dr. Dolly, for your kind introduction. I must congratulate Dr. Sneha Buyar for really, gathering galaxy of good speakers and panelists, and good moderators. And I'm really happy to share the podium with Dr. Bindal, Dr. Leela Joshi, Dr. Kavita Singh Urf Kavita Bindal, and and Dr. Parag Biniwale. I think it is always good to see, what is happening with these webinars. Learning is one thing, which good speakers are going to impart the learning and teaching to our obstetrician. But we are seeing so many friends on the one platform and so many faculties on the one platform. Someone sitting in Riva, Raipur, and Maharashtra. So I'm sure this is going to be a great webinar, and it's really going to be a very good learning when it comes to the sudden obstetric emergencies, which is what we really is the need of the hour. We want to reduce maternal morbidity and mortality, as Dr. Bintal and Dr. Kavita said that yes, we have to work at several levels and strengthen ourselves. So all the best to you, Sneha. All the best, Braj, and all of you who are aspiring to get your footholds in the Foxy at another step in the later. So all the best, and all the best for the this webinar as well. And thank you for inviting me to grace this occasion.
Thank you so
Thank you
much,
so
ma'am.
much, Dr. Archana. Thank you. With this, I would just request Dr. Parag to say a few words. From today, Amogs president and immediate past president, both of them are busy with their society programs. So we have our national coordinator of Amogs, Dr. Parag Biniwale, who is the ICOG chairperson elect as well, and a very dear friend from Pune. So we would request you, Parag, to say a few words.
Thank you. I'll not take time because I can see Geeta getting restless. She's waiting for quite some time. Just wanted to assure all the delegates and of course Dr. Jyoti Bindal and Kavita and all that what Dr. Bindal has stated is really disturbing. And I think Sneha, on behalf of Amogs, we should do our bit to connect to all the societies of Madhya Pradesh and even Chhattisgarh, who are the neighbors, and then try and do more and more activities so that we at least interact with them more number of times. Whatever little information we all have, we should share it with common members so that finally it will translate into betterment of health of our pregnant women and in general women as patients. So I think let's go ahead with the program, and thank you for the invite.
Yeah. Thank you so much, Parag. And we do have the programs in series planned. So this is the second episode with MPOG societies. Thank you so much. And without much ado, I just thank all of you and declare that the inauguration is done. And I would hand over the forum to Dr. Dolly now for the academic session. I welcome both the speakers, Dr. Geeta and Dr. Pushpa Somoshi, madam.
Thank you so much, ma'am. Now for the scientific session further, I invite my own friend, Dr. Brijbala Tiwari, ma'am, who is standing for the elections of committee chairperson in Environment Health Committee. So I request you all to support her as well. I welcome you, Dr. Brijbala, ma'am, to introduce our speaker of the first session, to start the first session.
Thank you, Ravi, for your warm wishes. So after blessings from our guest, we are going to start our session. And first topic is sudden obstetric collapse. For that, we are having chairpersons, our dear Dr. Shashibala Madam, and we call her PAM. She is immediate past president of Gwalior OBGY Society. She is national coordinator of International Academic Exchange Committee, FOXY, and she is very much into public health and family welfare department, MP government. She is chapter convener of Association of Medical Women of India. So I welcome you, Dr. Shashibala Madam. Our next chairperson is Dr. Shefali Shah. She is past secretary of Ratlam OBGY Society, and she is practicing in Ratlam since last 14 years, and she had been awarded Wonder Foxian Award, PMSA award, and she has special interest in infertility and endoscopy. So I will.
Thank you. Thank you, Braj. And first of all, let me acknowledge the presence of my seniors and I'm very happy to be here. Now we are waiting to hear from speaker Dr. Geeta Balsarkar. As you all know, she's a professor, unit chief, Naurozji Wadia Paternity Hospital, St. GS Medical College, Mumbai. She has been Joint Secretary, Mumbai Obstetric Gynecology Society of India. She is right now Joint Secretary. She is Editor Emeritus, Journal of Obstetrics and Gynecology of India. Past President, Association of Medical Women of India. Former President, Mumbai Menopause Society. So she has held so many posts. Chairperson, Young Talent Promotion Committee. She has been from 2013 to 16. And she's recipient of Hargobind Foundation Fellowship for Study of Fetal Medicine in 2008. So much to learn from her. Dr. Geeta, I welcome you to start your
Thank you. Thank you, Dr. Shashibala. It was a really very kind introduction. Can you see my slide? Yeah?
Yes.
Okay.
Full screen, yes.
Yeah. Before I start my actual topic on obstetric collapse or peripartum collapse, this is about real life case scenarios. Dr. Jyoti Bindal, in Mumbai, we have a district quality control of maternal health. So wherein actually it is the requirement of the government that every month maternal mortalities in the city of Mumbai, they are all reported very promptly. And I am also one of the members wherein we analyze at what level is the gap. Is it level 1, level 2, level 3, or what can be done, or anything could have been better to prevent this maternal mortality. We have such meetings every second Tuesday of the month, wherein the entire month's maternal mortality is analyzed and discussed. And the team consists of three obstetricians, one pathologist, one forensic person, a surgeon, an anesthetist, a staff nurse, and 3 admin persons.
So sorry to interrupt you, Geeta. This is happening in Madhya Pradesh also, and it's all over the country, I think. But and from that committee chairperson only I spoke the other day, and that's when I came to know the comparative thing, and that's
Madam Foxy, you can invite Foxy also to be a part of this committee. In Mumbai, we have invited Foxy and Amogs to be a part of this committee, wherein we can discuss the problem of the common obstetrician and gynecologist. And believe me, it has really helped us in reducing the mortality in Mumbai, maternal mortality in Mumbai, because Foxy, Amogs are also part of this committee. So we come to know the problem of an average practicing gynecologist at various levels, and then it is in detail, and we are already reaching our goals. Maharashtra, and in fact, Maharashtra is much better than Mumbai. And even in Mumbai, we are soon reaching our SDG 3 goals. So I think it is really very important that we discuss and analyze the cause of the maternal mortality. So coming to my topic here, the peripartum collapse, the real case life scenarios I'm going to discuss. So this is a case situation. I thought just theory top at 4 o'clock will be very boring. So I'm going to talk about cases. This is a second gravida, previous cesarean section. The last cesarean delivery was 1.5 years old. She comes with UPT positive, and she is wanting to have a medical abortion pill. The doctor prescribes it. Patient has minimal bleeding with pain in abdomen on and off, and she has vertigo. After 6 days, suddenly the patient has severe pain in abdomen and collapses at home. So the patient is brought to the hospital. She's almost like in a shock, pulse of 130, BP 70. So we all know that somewhere, that this could be a ruptured ectopic. So the differential diagnosis, clinical investigation, hemoglobin then showed 7 grams. USG showed adnexal mass with moderate fluid in the pouch of Douglas. So she was given aggressive fluid resuscitation, blood component organized. Actually, the thing is not whether it is laparotomy or laparoscopy, whatever the person, the gynecologist is skilled in, and whatever the resources that are available, both laparotomy and laparoscopy can be done. And whether conservative or the salpingectomy needs to be done, that I leave it to the gynecologist. But then the real story was that the emergency hemoglobin and ultrasound was done. Immediate laparotomy was done by the senior resident. 1,200 ml of blood in the peritoneal cavity. Salpingectomy was done. 1 pack cells was given, and patient had good recovery. So what saved the day is quick anticipation and confirmation of diagnosis. So we as obstetricians, sometimes we have to be very quick, and we have to think ectopic, at all early gestations who come with pain in abdomen, bleeding, especially giddiness, vertigo, vomiting, we have to think. So what is the learning drugs? Medical abortion drugs to be given with full counseling and plan for backup support. I always tell my patients whom I give medical pills that if you have heavy bleeding, pain, giddiness, you have to report to me and I can have you admitted for a day or two till the procedure is over. They have to know that there is a backup plan, and then if at all they need admission, this is where they will go and get admitted. There is a very important role of ultrasound, although it is very controversial whether we should do ultrasound before or whether we should do after to complete, to ensure that the medical termination is completed. But I would prefer to do an ultrasound before, just so that I don't miss an ectopic pregnancy. Undiagnosed ectopic pregnancy, nowadays we are seeing a lot of scar pregnancies, incomplete abortion. They can also cause severe hemorrhage, and they can have life-threatening complications in the current time of medical abortions. Many a times the medical abortion goes unsupervised. So if we just send them home and ask them to take the next pill after 48 hours, we might miss, 1 in 100 of a case who is just going to complicate. So overall, medical abortion drugs have reduced markedly the complication of surgical abortion, but yet we have to keep in mind that things like ectopic pregnancy, scar pregnancy, incomplete abortions have to be kept in mind. So how we can make our medical abortion safe for our pregnant women? So is it under the MTP Act? So we have to, under the MOHFW 2010 guidelines, they emphasize that the process and prescription of the drug is required. There we have to emphasize 3 visits. The first visit when we give the first drug, 1 visit in between, and 1 visit at completion. Chance of failure of medical method is there, and there could be need of surgical evacuation. Most of the time when we given medical pills, patients think that it can be 100% will be covered medically and there is no need for surgical. But no, we have to tell them that yes, if it doesn't get any complication is there, you may need surgical evacuation. Statement that the doctor can be contacted anytime. If they have anything out of the way, any symptoms is there, then they have to contact the doctor immediately. Reporting that you have explained the following things to the patient, and documentation is very mandatory. And RMP should maintain the stock register and record the pertinent details. Even in your stock register, you can record it. So coming to the next case, a woman second gravida, previous cesarean section 4 years ago, regular ANC visit, 32 weeks, coming with on and off pain in abdomen, more towards the epigastric pain, right hypochondrium, nausea, blood pressure normal. So she was prescribed antacid, H2 receptor antagonist. So is this okay? Do you all do this normally, or is there anything else you would like to do? So after 5 days of visit, patient comes with acute pain in abdomen, collapsed condition, BP 70/30, confused. There is generalized tender rigidity, fetal heart is not there. So what next? Resuscitation was done, aggressive fluid resuscitation, oxygen was given, IUFD was seen on ultrasound with free fluid in peritoneal cavity. So what is your DD and what will be your plan of management? So as a patient looked confused, oxygen saturation was 96, pulse 128, hemoglobin 10, IV crystalloid infusion, BP monitoring. So cesarean section was done, a fresh stillbirth was delivered, the scar was normal, and uterus well contracted. So unexplained shock and normal uterine finding. Any suggestions how to go about while the abdomen is opened? So while we are about to close the abdomen, we found some purulent material on the right side of abdomen. If an IUFD has occurred and the uterus is absolutely normal, remember that you have missed something and you have to look at the others in the abdomen. Just today, I was in the maternal mortality discussion meeting, and the surgeon was asking, can we make one abdomen ultrasound mandatory in the entire 9 months, so that we can pick up cases of liver problems, any gallbladder. We had one cholangitis patient, 19-year-old patient, who died of severe sepsis following cholangitis, for gallbladder, for spleen, for kidneys. So can we have one abdominal ultrasound in the entire course of 9 months? The surgeon was asking us. Carefully, we explored the bowel. Ruptured appendix was found. Appendicectomy was done. Post-operative period, blood pressure remained very low. Blood fluid was given, piperacillin tazobactam. Patient recovered slowly. but she had an uneventful recovery. So the learning lesson is non-obstetric causes has to be considered in all obstetric situations. We may be obstetricians, but patient is not going to come and tell us I have obstetric problem or I have non-obstetric problem. It is for us to realize whether it is an obstetric. So we have to train ourselves in diagnosing non-obstetric situations also. At least one whole abdominal scan should be done during the antenatal period and should be repeated in context of the clinical situation, especially if they have got epigastric pain. I also like to do a 2D echo, ECG, 2D echo, and a USG abdomen. These are very, very important, which helps us in your diagnosis. In the state of Tamil Nadu, maternal 2D echo is done compulsorily for all the patients. The government is offering maternal 2D echo free to all the patients. In the state of Maharashtra, the patient has to pay for that, but at least consider 2D echo or an ECG in those patients who complain of epigastric pain. Appendicitis and appendicular complication present very differently in pregnancy because of the anatomical shift and can be very difficult to diagnose. The clinical spectrum has to be kept in mind. Appendicitis can lead to life-threatening complication in pregnancy if there is delay in diagnosis and treatment. Many times we think it is preterm labor. We conserve till it is very late. Therefore, remember, any pain in abdomen is serious and do an ultrasound of the abdomen immediately. So near miss situation 3, a second gravida PPROM 30 weeks, managed conservatively for 7 days with antibiotics, steroid, on rising temperature and less fetal movement. Induction of labor was done. Patient delivered 1.24 kg baby. Baby was shifted to NICU. Till then, everything is fine here. So we think, yes, okay, we have finished with the case. Is it? No. The problem starts now. The next day morning round, when the round was taken by the staff, patient was like very cold, pulse was 100 per 110, BP 90/60, patient was drowsy. So immediately IV fluid was started. After 1 hour, pulse became 120, BP 80/60, she had a temperature. So what's your provisional diagnosis? Your management lines in order of priority, we all know this is sepsis. So we have to have guidelines on the surviving sepsis campaign guidelines. So this was a simple sepsis. So it doesn't take much time to move from simple sepsis to septic shock. This patient has to be given oxygen, investigations for hemoglobin, total count, all the bloods and vaginal swab, serum lactate, blood gas, blood component. USG was done to rule out any retained any pieces, collection, full clinical examination for any bleeding or any septic foci, fluid resuscitation. So input-output chart, IV fluids were started. So what we need is early and aggressive resuscitation in case of septic shock. Even simple sepsis can move progressively and patient can land up in septic shock. The normal saline ringer lactate in bolus dose of 1000 ml, where give 30 ml per kg body weight over 3 hours. This is in Surviving Sepsis Guideline 2016. If patient does not respond to fluid resuscitation, then you have to immediately move to vasopressor therapy. Vasopressor therapy needs to be started. Norepinephrine is a first line therapy, and we need to know how to start norepinephrine if there be a need. Most time we feel that we don't know, or we can call a medical person, but in case somebody is not available, we should also get trained in this. So sepsis bundle is you have to measure the lactate level, re-measure if initial lactate is more than 2 millimole per liter, obtain blood culture. Prior to administration of antibiotics, we have to administer broad spectrum antibiotics. We have to give rapid administration of 30 ml per kg crystalloid for hypotension or lactate more than 4 millimoles per liter, and add vasopressor if patient is hypotensive during or after fluid resuscitation to maintain the mean arterial pressure more than 65 millimeters of mercury. We have to treat the underlying cause of sepsis, be it retained products of conception, termination of delivery, or debridement of the wound. Time 0 or the time of presentation is defined as the time of triage in the emergency department, presenting from other care venue from the earliest annotation consistent with all the elements of sepsis, and we have to act from time 0. What is a key recommendation? In case of obstetric collapse, think of sepsis. What is the cause and whether it is coexisting. Subtle signs of sepsis should be picked up at earliest for timely diagnosis. It could be thrombophlebitis at your IV site, or it could be redness and swelling of the calf. Sometimes we have to be very, very sensitive. Any post-delivery patient, we have to see talk, mentation, whether patient is talking properly, whether she is answering your questions, whether she is understanding that she is in hospital. Touch. The moment you touch, you will feel whether she is warm, she is cold, what is the pulse, what is the wound temperature. Count. We have to count the respiratory rate and screen for sepsis using the Q-SOFA score. Assess for organ dysfunction by SOFA score and the Muse for monitoring. Lactate estimation is not a one-time investigation. Sepsis bundle should be initiated in the first 1 hour. Prevent sepsis by appropriate infection prevention and control measures in all obstetric situations. Create awareness among junior staff during rounds on prevention, early recognition, and sepsis management. So this is very important. Talk, touch, count, screen, and assess. So this we have to remember even for all normal vaginal deliveries. And we have to train our staff. If they don't talk properly, if the touch is not okay, if what is the respiratory rate and the pulse count, we have to screen for sepsis and assess for any organ dysfunction. This is very, very important. And coming to the next case. Now this patient is gravida 4, para 1-3 abortions, 2 MTP. So she had her last cesarean birth 7 years back. And then uneventful antenatal record, normal USG for fetal growth, admitted at 11 p.m. in the night, active labor, patient delivered at 4 a.m. in the morning. Patient failed to deliver the placenta, and the active management of third stage already done. Oxytocin infusion was given. Anesthetist was called for MRP. Suddenly, patient collapsed. Pulse BP not recordable. This is at 4 a.m. in the morning. So aggressive resuscitation started. Pulse felt within 15 minutes. MRP was done quickly without anesthesia as anesthetist was busy resuscitating patient. For continued oozing, either you can use a Bakri balloon or a condom tamponade was kept for 24 hours. 2 units of RBCs, crystalloids, antibiotics, and oxytocin was given. Patient was in the puerperium and was discharged after 5 days. So what saved the story? The quick thinking of the obstetrician. So obstetric collapse, alert and awareness saves the day. Antenatal care, pick up high-risk cases. Write a note, mention what all conditions could be putting her at high risk. Separately, keep on writing one below the other. If there is previous cesarean section, any medical comorbidities, diabetes, thyroid, hypertension, nutritional deficiency, anemia, if the patient is at high risk of sepsis, high risk of venous thromboembolism, and labor complexities anticipation, you can note it down. Write in your antenatal paper. Every obstetric unit and every person of the obstetric team must be trained and skilled to manage the collapse. You know what happens normally when a patient collapses? 10 people run to get a Foley's catheter. 2 will be trying to put the catheter together. So everybody should be delegated their own work. Anesthetist will manage the head end. Staff should help the anesthetist in taking the IV. Somebody should put, one person should put the Foley's, one person should assess the patient. So it should be a teamwork, and it has to run smoothly. Team will have to manage then and there. There is no time for immediate referral. Referral in unsettled case may worsen the situation because of multiple issues. The referral, there should be a sound referral system whenever we transfer patients or we get patients from the other hospital. Complete over from one doctor to the other has to be there. Therefore, in every small nursing home or every small hospital, whenever there is a collapse, everybody, the obstetrician has to give work. Anesthetist, you resuscitate the patient. This one, you put the catheter. This, you bring the Bakri balloon. So one person should loudly delegate the work in the entire team. Every labor room must be equipped to deal with any obstetric collapse. Emergency drugs, IV fluid availability has to be there. Suction, mouth gag, oxygen with mask, Boyle's trolley with accessories, all the monitors, pulse oximeter, cardiac monitor, availability of senior anesthetist, obstetrician, blood banking services, senior nursing staff, and good connectivity to blood bank and ICU, and feasibility to do certain operative procedures if required. Very, very important. And coming to the next case, a 27-year-old primary gravida cesarean for IUGR and oligohydramnios at 38 weeks at a peripheral health center. 6 hours later, patient presents from bleeding from cesarean section wound and she's unstable. There are features of hemorrhagic shock. Abdomen is tense. Urine output is 100 ml. Uterus is deviated to one side. How do you manage such a situation? So she was given 2 pints the pack cells and was referred to tertiary care for emergency.
मेरी पानी की bottle दे देना अंदर से.
When we do laparotomy, there was generalized oozing from all layers, broad ligament hematoma, 700 ml blood in the peritoneal cavity, right salpingo-oophorectomy, uterine artery devascularization, and Hayman suturing was done. All in all, she required 9 units of packed cells, 10 units of FFP, 9-unit platelet transfusion, but she developed acute kidney injury requiring hemodialysis. She stayed in the hospital for 60 days and she was discharged eventually after 60 days. So these are the risk factors for re-laparotomy after cesarean section in a tertiary care hospital. So there are a lot of indications for re-laparotomy. It could be because of atonic PPH developing 5 to 6 hours later. It could be because of traumatic PPH, rectus sheath hematoma, we have to keep in mind, burst abdomen, peritonitis, infection, adhesions. So these are all indications for re-laparotomy. So the time interval taking from between the original cesarean section to re-laparotomy, that is what gives us the prognosis of the patient. The more the time lapse, the worse is the prognosis. So all patients are at high risk for PPH and they need extra close monitoring for vitals and bleeding PV. Please do not discontinue oxytocin in the post-cesarean care. Counseling for the possibility of complications to attendant should be done in all high-risk cases. Vigilance and prompt action. No delay should be done in exploration and confirming the cause. Most of the mortality that happens is in re-exploration is because of the delay. There should not be any delay in the exploration. There can be more than one etiology of PPH like vaginal, cervical cause or any drugs like nifedipine. If patient is on aspirin, nowadays most of our IVF patients are on low molecular weight heparin, aspirin, Maxelf. They all increase the possibility of postpartum hemorrhage. PPH is a nightmare to the obstetrician, more so after a cesarean section. So what are the learning pearls out of this storm? Proper hemostasis must be ensured. Ever confident you are of your hemostasis, still take 5 minutes off, wait, ask the anesthetist the blood pressure, ask the sister to do the mop count, instrument count, and recheck your hemostasis. A secondary look for your proper hemostasis has to be done. Good surgical technique, of course, it needs training, supervision, and flexible approach as per the situation. Close vital monitoring must be strictly followed after any surgery. Early diagnosis and prompt intervention would have prevented DIC and acute kidney injury. So appropriate, aggressive, and timely management at the tertiary care center saved this particular patient. Even if she would have been operated a little early, her prognosis would have become much better. Now coming to the 6th case, women admitted for cesarean section with diagnosed case of bronchial asthma on medication since last 1 month. Just after the baby delivery, patient developed severe hypotension, not responding to IV vasopressors. She was intubated, put on intermittent positive pressure ventilation and steroid given, was not maintaining oxygen saturation and blood pressure, kept to ICU. ECG showed non-specific changes, generalized 2D echo showed generalized hypokinesia. Left ventricular ejection fraction was only 30%, severe MR, TR, and she was diagnosed as a case of peripartum cardiomyopathy. She responded to ACE inhibitors, digoxin, antibiotics, low molecular weight heparin, and Lasix. Keep peripartum cardiomyopathy in your mind if there is a sudden collapse. She was discharged on 10th day in stable condition. She's still on treatment for cardiomyopathy, even though she's now 1 year post-delivery. She's still on treatment for peripartum cardiomyopathy. So there are leading cause of anesthetic near miss like patient profile, surgical factors. There could be human errors, equipment failure, drug interaction. So the key implementation practices are risk stratification of patient as pre-anesthetic checkup and evaluation in emergency situation. Other than emergency situation, wherever possible, always have a pre-anesthetic checkup. They are sure to pick up something more than what we can do. Preparedness and check all the equipment, gas supplies, senior inputs and presence in high-risk cases. This is where we need seniors to give their input of what could have saved this particular patient, so that next fighting patients, the similar patients that we see will not lose their life. Alertness and awareness of the obstetric anesthetic issues with regular teachings. Now coming to the next case, grand multipara, admitted to emergency ward, 11 p.m., obstructed labor, BP 130/80, maternal exhaustion, thick meconium. With antibiotic and fluid resuscitation, cesarean section was done. 4 kg baby was delivered. Slight extension of the incision, which was repaired well. After shifting patient to post-operative ward, after 1 hour, patient has blood pressure of 80, 30 with respiration, confused look, drowsy. Examination showed no pallor, no evident sign of hemorrhage. Bedside hemoglobin was 10.8 grams per dl. Since she came in emergency, nobody did her blood sugar. But when she started behaving drowsy, we got the blood sugar and it came very high, 450 and odd. And urine sugar was 3 plus, urine ketones was 2 plus. Physician was consulted. We started the insulin glucose drip. Normal saline with insulin was started. In 1 hour, all the vitals improved, breathing improved, blood sugar came to 321. Then insulin was continued. Again, physician guided further management, and eventually patient made a good recovery. Keep the blood sugar in mind, both hypoglycemia as well as hyperglycemia whenever patient has an obstetric collapse. So the learning lesson is screening protocol for gestational diabetes is a must in antenatal period. In all risk case, screening with glucose challenge should be repeated in the 3rd trimester. It can be a good practice to check all emergency laboring women. We should be able to do the blood sugar while they are in labor. Knowledge for diagnosis of diabetic ketoacidosis and basic principles of how to manage this particular patient is required for the obstetric healthcare team. Coming to the next case, 36-year-old woman conceived after IUI, and working in Dubai, lives in village till the antenatal care till 24 weeks with everything normal. She comes for checkup at 34 weeks, complain of pain in abdomen, mild edema, BP 176, 115, fetal growth normal, proteinuria, LFT, RFT, hemocrit normal. Blood pressure was measured at PHC was high, therefore nifedipine was started and patient advised admission and counseled about possibility of early delivery. Labetalol, nifedipine and Maxelfen steroid were given. She got admitted after 1.5 days. She said, I'll go home now and I'll get my relative and come. So she came after 1.5 days. BP was 168/100. Rest everything was done. Cesarean section was done. Alive 1.8 kg. Female child delivered. Cried immediately. BP in the post-op period remained in the range of 180, 150 to 170. Patient kept on nifedipine and was given Maxel for 24 hours. On second day, almost about 30 hours after cesarean section, patient had sudden cough, breathlessness, and restlessness. BP was 220/118. Pulse was 115. Oxygen saturation came down to 70. Chest, I could not find whether it was a wheeze or clear breath sound. Sometimes we are also stressed when we go and see such a patient, and I really could not make out, but I could know that the chest was not clear. So help was called, oxygen started, propped up position, labetalol was given, anesthetic called, mask oxygen was started after 10 minutes. Pulse was not recordable, oxygen saturation 55%. On assisted respiration, patient was shifted to ICU in ambulance, anesthetist and no attendant was expected to reach within 15 minutes. In ICU, she was put on ventilator, and eventually, after 15 minutes, BP came up, oxygen saturation improved. After 1 hour, patient had spontaneous respiration. She went off of ventilatory support after 5 days. So what are the factors that cause pulmonary edema in severe preeclampsia? Probably fluid overload. Prehydration is given for regional anesthesia, prolonged Maxelf and oxytocin, postpartum immobilization, renal dysfunction or acute tubular necrosis, untreated severe hypertension, which was the case in this patient, low serum colloid osmotic pressure, sepsis. All these can push a patient into pulmonary edema whenever these patients are having PIH or severe preeclampsia. So postpartum period is close vigilance for complications like eclampsia, PPH, ARDS, neurological complications. There are so many cases I can tell you. One patient complained to me that after delivery, she's not able to hold the baby, at my night rounds. She said, I'm having, my baby is falling off my hand. And I was also young lecturer then. I didn't take it very seriously. I said, okay, I will see you tomorrow. I'll show my boss. But in the night, she had a full stroke. And she was rightly complaining that she was not able to lift the baby from the left side because some sort of weakness had already set in. So neurological complications are not normal following a normal delivery. So please look for it. Monitoring for severe features of preeclampsia should be continued. Even if patient is no known case of severe preeclampsia, we have delivered the baby, it doesn't end there. We have to monitor the patient. This patient developed pulmonary edema 30 hours after cesarean section. We have to monitor BP 4 to 6 hourly during the day and for at least 3 days postpartum. The preeclampsia may develop either de novo, intra, or early postpartum, and such cases are managed on the same principle as antenatal preeclampsia with added careful assessment for retained products of conception. So what are the learning pearls? What saved the patient? Quick action, intubation, referral to ICU, despite resistance from the patient relatives. You are saying, wait, now husband is coming, he has left home, he will be there in 15 minutes. No, we did not have any time to wait. Firm and confident communication. No, this patient is serious and this now we need to have decision making, system implementation. Keep all patients of preeclampsia, especially with high features, for 48 hours in HDU or at least somewhere closer to where the sister sits, so that monitoring is better. Protocol for antihypertensive drugs, lab investigation, and postpartum follow-up patients for preeclampsia should be there as per the institution protocols. So prenatal care is one of the most effective way to reduce maternal mortality because it identifies complications or high risk before the emergency situations. So thank you for a very patient hearing.
Thank you so much, Dr. Geeta Madam. And first of all, I would like to thank the esteemed faculties for making me the part of this webinar. And as far as we are concerned, ma'am, the private practitioners, we are often afraid of obstetric emergencies. So you have made us so much aware of this, like ectopic pregnancy. Sometimes we forget ectopic pregnancy. So we have to think of ectopic pregnancy. And as you rightly said, that we have to think of non-obstetric emergencies too, like appendicitis, gallbladder, liver, that should be taken care of. We should do the 2D echo of the patient and the whole abdomen USG at least once. And of course, the medical emergency should not be forgotten and should always be kept in mind, like peripartum cardiomyopathy, as you said, diabetic ketoacidosis and pulmonary edema. So it was a really enlightening talk, madam. Thank you so much. And it is the take-home messages were very important for people like us. Thank you so much, ma'am.
Really, Geeta, it was eye-opener and you have sorted it out. Now it goes into your mind, learning. That was a very nice point you have put up. So learning, we have to take lessons. So once bitten, twice shy, we must be look out for. And ignorance is bliss. Because we don't know, then everything is fine. Cozy,
Yes,
bacha ho gaya, the puerperal sepsis sets in. So many things. So post-delivery also. So thank you so much. I really enjoyed and very informative.
Thank
Ma'am,
you.
I want to ask one question.
Yes.
Ma'am, after 6 hours of delivery, she was G2P1 and she delivered normally. She was only RH negative and on CSC, she delivered normally. After 6 hours, she shoot up BP and she died of after within half an hour.
So
What may be the cause?
see, I am not covered pulmonary embolism.
Embolism.
That is something I am not covered. It is very difficult.
Only BP was shoot up and
Amniotic fluid
proteinuria was 2+.
So she's an eclamptic and she has died of pulmonary edema. So what we need to remember is that severe preeclampsia can develop even after post-delivery. Though I have covered quite a bit, I have not covered also quite a bit. I have not covered pulmonary embolism. I have not covered a lot of other things. So I thought in your next series, I will take pulmonary embolism as a separate lecture. And it is actually very important. I have got a lot of good points to take. Now, this particular patient could have had preeclampsia, severe preeclampsia, or she could have had peripartum cardiomyopathy, which we really don't know. Unless we investigate this patient or she has a previous 2D echo or you have done some bloods or anything, we won't really be able to tell this particular thing.
Yes.
Thank you so much. Thank you so much, Chairpersons, Pam Madam and Shefali, for bringing the important concluding remarks. So as we are having short of time, we are moving towards our second session, and that is also very important, fetal surveillance. And for that, we are having chairpersons, Dr. Rekha Singhal from RIVA. She is excellent, very, very active, enthusiastic Foxian, and she is the secretary of RIVA OBGY Society. As a society member, she had received so many awards in last 2 years. Milan Smriti Award 22, Durusha Award 22, Special Award for Cervical Cancer in 21, and Gangadharan and Chitrahara Award for Preventive and Research Oncology. And she had presented papers many times. So she's very active, and I think we are having next Ampog in Riva. So we are eagerly waiting, Rekha. So welcome for this webinar. Now our next chairperson is Dr. Mona Gupta. She's very dear friend of ours, and she's consultant gynecologist and IVF specialist at Ujjain. So I welcome you both. Just before that, I would like to add one point regarding MMR in high MMR in MP. It is particularly in one area only, Khargon. I attended one, represented one meeting, and there are the main issue of transportation. So I think Bindal madam is not here. I will talk to her personally for this. So I invite both the chairperson to invite our eminent speaker, Dr. Pushpa madam, for her talk on fetal surveillance. Over to you, Dr. Rekha and Dr. Muna. Rekha or anyone can introduce madam.
Welcome, Dr. Pushpa madam. Heartiest welcome you.
Dr. Rekha, you have to
ma'am.
Is somebody introducing or should I introduce madam?
It is not visible. Ma'am, it is not visible.
Yeah, okay. Madam is a very senior professor since
Ma'am,
last.
it is not visible. CV is not visible.
No, it is visible very much. I think you are from mobile phone. That's the reason.
Yeah.
So I will just quickly go ahead. That madam, because she is very closely known to me. She belongs to our region, and she is a very senior professor from the PDMMC Amravati. Very academic, focused personality. Of course, a very, very inspirational personality for, of course, because she is a UG and PG examiner and UG and PG teacher, faculty in many national and state zonal conferences. She is the member faculty of medicine MOHS, and of course, she has had so many awards and achievements. So the list is long. So without much ado, I think we should listen to you, madam. Over to you for your important talk on fetal surveillance.
I will share my screen.
You can see the share screen icon, no, madam?
Sandy?
Is it visible?
No, not yet. That's the reason I'm saying at the bottom of your screen, there is a green color icon, share screen.
Yes.
Please click on that. Yes, it is showing now. Yeah. Just make it slideshow, that's all.
Perfect.
Yes, perfect.
Good evening, all of you. At the outset, I would like to thank and also wish Dr. Sneha best wishes for her future endeavors, and also Dr. Brishbala Tiwari.
Thank you, ma'am.
My best wishes with both of you.
Thank you.
In obstetrics, apart from the mother, the baby is equally important, because finally our aim is to give a full-term healthy living child to a mother without affecting her own health. So I'll be talking about fetal surveillance, especially with the help of continuous electronic fetal monitoring with the help of cardiotocography. So the goal is to identify the fetus at risk, timely intervene and rescue the fetus from intrapartum hypoxic insult, thereby preventing neonatal asphyxia and long-term morbidity in the baby. It can be done by intermittent auscultation that we conventionally do, usually in all patients we are monitoring. But electronic fetal monitoring definitely helps to pick up many of these abnormalities which we might miss with intermittent auscultation. Then, of course, there are others like fetal scalp pH with blood sampling, fetal pulse oximetry, fetal scalp lactate testing, ST waveform analysis. But out of this, cardiotocography and electronic fetal monitoring, it is most practical. And a busy hospital should have this in labor room for this continuous fetal heart rate monitoring, because it is most feasible and most helpful among all these methods. So whenever we are carrying out cardiotocography, we are thinking about the CTG machine. We should have an ideal CTG machine. Which patient we should monitor? Each and every patient, does she require monitoring? Then who should interpret the results? And of course, the intervention which is necessary after interpreting the results. So all these things are important. Of course, if I'm going to talk about cardiotocography, let me tell you that it is not the gold standard, or you can say it is gold standard, but it has got some technical pitfalls. There is differences in recording techniques. There is lack of uniform classification system. There might be confusion due to many influences on the fetal heart rhythm. There are many reasons why the fetal heart rate might be altered, maybe for time being. It has got low validity with high incidence of false positive findings. It is there is substantial intra and inter-observable variation regarding the interpretation of CTG. This is most important. Then lack of agreement on how, when, and whom to monitor. And of course, it is said to lead to increase in artificial deliveries, that it either intervention in form of instrumental deliveries or cesarean section. It has got high sensitivity, but it has got low specificity. That is, normal CTG is definitely reassuring, but a large number of fetuses with abnormal CTG pattern do not have hypoxia of clinical significance. So we might tend to overdiagnose. That is why proper interpretation and intervention whenever necessary, that is important. Now, what are the indications? It should be offered and recommended for high-risk pregnancies where there is an increased risk of perinatal death or cerebral palsy or neonatal encephalopathy. Patients with previous such histories, definitely they should deserve this continuous monitoring. Continuous monitoring should also be used in all the patients in whom we have induced or augmented labor with the help of oxytocin or misoprostol. Then whenever the mother is having some high-risk conditions like hypertension in pregnancy or diabetes mellitus, for example, or if there is multiple gestation, the pregnancy has become post-dated, or if the patient is given Tolac for previous cesarean section, or if the baby is having intrauterine growth restriction. Whenever there is oligohydramnios, PROM, congenital malformations, antepartum hemorrhage, or when the meconium is meconium stained. So all these are indications for continuous electronic fetal rate monitoring. And of course, whenever we are monitoring with the help of intermittent auscultation, whenever we notice that the fetal heart rate falls below 110, or if it is greater than 160, or if there are any decelerations, maybe post contraction, but if there are decelerations, or if anew any intrapartum factors develop, all these patients also should be subjected for continuous electronic fetal monitoring. The aim of CTG as a tool for intrapartum monitoring is to identify fetuses that are being inadequately oxygenated. It enables us to take appropriate action before the occurrence of injury like HIE, which might be a short-term sequelae, or a long-term sequelae like cerebral palsy. In case the CTG is normal or reactive, it definitely provides reassurance to the mother, to the relatives, and to us also. And of course, it avoids unnecessary obstetric interventions. But most important, for the monitoring to be effective, the test should be performed correctly, its results must be interpreted satisfactorily, and finally, this interpretation must provoke an appropriate response. For this, we should remember this mnemonic, Dr. C. Brevedo. So in this, DR, that is doctor, stands for defining risk. That is, as I have already enumerated, there are certain maternal risk factors, patients who are having hypertensive disorders, patients who are diabetic, or the baby who is having IUGR, or if there is oligohydramnias. So we should identify these risk factors, and these patients definitely require close monitoring. Then contractions, the frequency, duration, and intensity of the contractions. The basal heart rate, it should be somewhere between 110 to 160. If it is less than 110, when we were students, we used to say that anything less than 120 is bradycardia, but now we know that 110 can be normal. But if it falls below 110, we should be worried. Then there should be variability. All this I am talking about in the CTGs. So there should be variability with 5 to 25 beats. And there should be definitely some acceleration, at least 2 in 20 minutes. Whenever there are decelerations, they should be considered as abnormal. So after carrying out all this interpretation, that is seeing the report in details, so that we can finally have an overall impression and we can assess the risk and whether we should intervene or continue with monitoring and deliver the patient vaginally. That can be decided at the end of all this close monitoring of that report. So few basic definitions. Basal fetal heart rate, it is determined over a period of 5 to 10 minutes, and it is expressed as beats per minute. As I've told you, it is somewhere between 110 to 160. Whenever there is fall in fetal heart rate, it is above 100, but less than 110, it is moderate bradycardia. If it falls below 100, it is severe bradycardia. If it is between 161 to 180, it is moderate tachycardia. More than 180, it is severe tachycardia. Then what is baseline variability? It is a measure of the interplay, that is push and pull effect between the sympathetic and parasympathetic nervous systems of the baby. Lack of variability is ominous. In fact, variability is the best indicator of fetal well-being. So this shows reduced variability, and this simply might indicate that the baby might be sleeping. So we might have applied this test when the baby is sleeping or quiet or quiescent, or it can be because we have done this in premature patient, but it can also indicate that there is definitely hypoxia or there might be some CNS abnormality also. Accelerations are transient increase above the fetal heart rate baseline. Any fetal movement should elicit accelerations. Contractions also affect the accelerations. And whenever there are accelerations, it is a reassuring finding and it is a positive finding. So a normal CTG, to interpret it as normal, it should have a reassuring pattern. Basal fetal heart rate should be between 130 to 140. Beat to beat variation and long-term variability should be preserved. Acceleration should last for 15 or more seconds above the baseline and peak at 15 or more beats per minute. This is a normal CTG with accelerations intermittently. Decelerations, they can be early, which are because of head compression. They can be late because of uteroplacental insufficiency, or they can be variable because of cord compression. Or it can indicate some primary CNS dysfunction. You can remember this. that head comes first in most of the patients. So early decelerations are because of head compression. Placenta comes last. So late decelerations, they are because of uteroplacental insufficiency. And cord comes in between. So whenever there are variable deceleration, cord compression must be the reason. Early decelerations, they are gradual in onset and they they appear before peak of contraction. They return to baseline before the end of contraction. They are uniform in shape, similar to one another. The cause is most of the times head compression, which causes increase in intracranial pressure and vagal nerve stimulation. And so there is accompanying decrease in fetal heart rate. It can indicate cephalopelvic disproportion. That is why there is head compression, and we should reassess the patient and think whether we should continue giving trial or should intervene. But definitely it is not associated with hypoxia or acidosis. These are the early decelerations. No intervention is required in such cases. Late decelerations, there is decrease in the fetal heart rate, which begins after contraction. And it is delayed in onset. That is, also it returns a bit late to fetal baseline after contraction ends. Therefore, the recovery is late, recovery of the fetal heart rate. It indicates fetal metabolic acidosis leading to hypoxic injury to the fetus. And the cause is uteroplacental insufficiency. These are late decelerations. That is, they appear late and the recovery also is late. Even after the contraction has passed off, they continue. We need to intervene by simple things like lateral positioning. If the patient is on her back, she should be given lateral position. If she is on oxytocin drip, we should stop oxytocin. We can provide oxygen, nasal oxygen. If she is not hydrated well, IV fluid can be given rapidly as a bolus, which will hydrate the patient. And we should notify the consultant, or that is, if this NST is or this CTG is monitored by sisters or junior doctors, the consultant should be notified. And we should see that delivery is expedited. Whenever there are prolonged deceleration, they are going to last for 2 to 3 minutes. It is classified as non-reassuring. If it lasts for longer than 3 minutes, it is abnormal. These are prolonged deceleration. They are reversible, but there are certain conditions which are reversible, like if there is hypotension, if there is excessive uterine activity and sustained umbilical cord compression. All this we can correct by giving hydration to the patient. If oxytocin is given, we should stop it. Unfortunately, if we have administered misoprostol, we cannot do anything about it. And by changing the position, the cord compression can be released. But then there can be non-reversible causes, like there can be abruption, there might be cord prolapse, or there can be rupture of the skull. And in these conditions, definitely we will have to deliver the baby early. Then there are variable decelerations. These are U, V, or W shape. That is, they are of varied shape. And they are not only variable in timing, but also duration, depth, and they are not at all uniform. And most of the times, the cord compression is the cause. These are the variable decelerations. We need to intervene, again, by changing the position of the patient. We should rule out prolapse cord by vaginal examination. Oxytocin, again, if it is there running, it should be stopped. If there is case of oligohydramnios, which is causing cord compression, we can give amnio infusion. That is, we can think about amnio infusion. Then there are atypical or complicated variable deceleration. Drop more than 60 beats per minute, lasting for more than 60 seconds. Then loss of shouldering. And there is biphasic deceleration pattern. That is, they do not recover as expected. Even there is loss of primary or secondary rise in basal fetal heart rate, loss of baseline variability, and even within deceleration, there is loss of variability. It indicates that fetus might be losing its capacity to compensate, and we have to help the fetus to deliver. Now, there are other findings that we might notice, like fetal tachycardia. If it is between 160 to 180, it is okay. That is, we can think about some causes which might be reversible. It might indicate that the mother might be having tachycardia because of fever or she might be given certain drugs like beta-mimetic drugs. It also might indicate that there might be fetal anemia, but it can be because of chorioamnionitis. But most important, hypoxia is an important cause. Coming to bradycardia, periods of baseline rate falling below 110 for a prolonged period definitely it is abnormal. Whenever it is for more than 3 minutes, we have to call for help. Whenever it is prolonging for 6 minutes, intervention has to be provided. If it is lasting for 9 minutes, we have to move the patient to the theater because she might require cesarean section, or we might have to deliver her rapidly if she is fit to deliver by either vacuum extraction or forceps application. But if it is very much prolonged, definitely we have to terminate the pregnancy immediately by whatever means possible, either application of forceps, vacuum, or cesarean section. Then there is sinusoidal pattern. This is not a normal pattern. Here the baseline is stable, but it has having regular sine wave oscillations. Amplitude is only between 5 to 15 beats per minute, and there is reduced or even absent variability, and there are no accelerations. It is associated with severe chronic fetal anemia, or more important, severe hypoxia and acidosis, in which case we have to intervene. This is sinusoidal pattern. If it is persistent in spite of cycling means, as I've told you, sometimes the baby is quiescent or it might be sleeping. But if we repeat that after some time, after giving some hydration to the mother or after asking her to eat something and repeat this, and this sinusoidal pattern is persisting, it definitely is an indication for intervention. And more important, it might also indicate vasa previa abruptio and maternal hemorrhage. So we have to be vigilant whenever there is sinusoidal pattern. It simply may not be simply a quiet baby or sleeping baby, but it can be a severe condition like vasa previa or abruption. Then there is another saltatory pattern. The exact mechanism why it is seen in some patients, it is still debated. It may be associated with rapidly evolving hypoxia. And sometimes it might be associated with active maternal pushing. With the recent labor care guide of WHO, it asks us not to ask the patient to push. That is active bearing down, it is no now. Whenever patient feels like pushing herself, then only she should bear down. But we used to ask the patient to push whenever we think that the patient is now in second stage of labor and she is now bound to deliver. So this might be associated with saltatory pattern. Again, if she is on oxytocin infusion, it is better to stop. It might be causing hyperstimulation or tachysystole, and it can affect the fetal heart rate. It reflects attempts by the autonomic nervous system of the fetus to maintain stable baseline when there is rapidly evolving hypoxic stress. This is the saltatory pattern. So the intervention that we need to carry out is, if the patient is bearing down, pushing, stop, ask her to stop pushing, stop oxytocin. And sometimes if there is hypertonic contraction, we might have to consider even the tocolysis to relieve the stress and improve oxygenation to the baby. So to sum up, whenever we see the ECG pattern with early deceleration, it is usually seen in the second stage of labor because of head compression. No intervention is required. When the deceleration is late, it indicates uterine hypercontractility. So if she is given oxytocin, we have to consider stopping it and even consider terbutaline if necessary. And we can give lateral position to the patient and give nasal oxygen at 8 to 10 liters per minute. If the deceleration is variable, it indicates cord compression. If it is because of oligohydramnios, we can consider amnio infusion, or we can change the position of the patient, turn it to lateral position. Now, whenever there is fetal tachycardia, it can be because of tachycardia in the mother, maternal fever, or dehydration. So we can correct her dehydration by infusing rapid intravenous fluid. It can indicate sepsis, so we have to think about infections to the mother and hydrate the mother. If she is being given tocolysis for any reason, this can also be reason for tachycardia. So if we are waiting for the patient to have the effect of steroid, if we have come with a patient of preterm labor and we want to delay the labor to have the effect of corticosteroids, she might be given tocolysis. So this also might be one of the reasons that the baby might develop tachycardia. So features associated with fetal compromise are fetal tachycardia more than 180, reduced baseline variability, complicated variables, late decelerations, prolonged decelerations more than 3 minutes. I have already told you about if it is 6 minutes, 9 minutes, 12 minutes, then how to intervene. So in these conditions, we have to give oxygen, recommended in those with reduced oxygen saturation, that is maternal oxygen saturation, because she might be having maternal hypovolemia or because of abruption. We have to rapidly infuse IV fluid to improve venous return, thereby increasing the cardiac output and thereby increasing the uterine blood flow. So if the patient is receiving oxytocin, this also dilutes oxytocin, thereby preventing hyperstimulation of the uterus. Maternal repositioning, giving again in WHO labor guide, the alert line is given, or we have to be alert if the patient is lying on her back. So we have to always ask the patient either she should be moving about or she should be taking preferably left lateral position. Again, if she's being on oxytocin, we have to stop that. And we have to carry out combination of different interventions. So intervention based on CTG, that is, if we want to further confirm whether baby is having any problem, if the facilities are available, we can carry out fetal scald blood sampling to know the pH and to determine the lactate levels. And we should be anticipating that the baby might require resuscitation. So neonatologist should be on call, should be ready in delivery, and expedite vaginal delivery if it is possible. If she is in second stage, we can apply forceps or vacuum if all the prerequisites are fulfilled. Or we might have to resort to cesarean section. So the take-home message is, take all the things of Dr. Brevedo, that mnemonics that I've told you, into consideration, especially the overall clinical picture like maternal diseases, the conditions in the fetus like IUG or oligohydramnios, if she's being given Tolac in cases of previous cesarean section, apart from all the features of CTG. So only CTG or only the features of cardiotocogram, they are not sufficient. We have to take into consideration all the other factors, maternal as well as fetal factors, the uterine contractions, whether there is hypertonus, whether she is being augmented with oxytocin. All these factors, they will have to be taken into consideration before deciding intervention. So isolated moderate bradycardia between 100 to 110 or absent accelerations, early decelerations, and uncomplicated variable decelerations are unlikely to be associated with significant fetal compromise. So we have to think twice. We don't have to jump to conclusion that she needs cesarean section immediately. We can give time, carry out interventions, and correct the hypoxia and deliver the patient vaginally. Because not all decelerations, they require resuscitation. Intervention should be carried out if there is severe tachycardia, reduced baseline variability less than 5, complicated variable decelerations, late and prolonged decelerations for more than 3 minutes, or severe bradycardia, which is lasting for more than 3 minutes. So this is how we have to take into consideration all the factors which are going to bring about changes in the CTG. So only isolated CTG is not going to tell you that you should intervene immediately. So thank you for your patient list.
Thank you so much, ma'am. May I request our chairperson to give their remarks, concluding remarks? It was excellent talk, madam. So many take home, because fetal surveillance by CT is really very, very important. And we need to take admission CTG as well. Do we have Dr. Moona and Rekha?
Yes, sir.
Yeah,
Thank
please.
you so much, respected ma'am, for such a nice informative talk on fetal surveillance. And this type of fetal surveillance on practical uh, basis, ma'am, definitely it may reduce the cesarean rate also, and uh, it may increase the good fetal outcome also.
Sure.
Thank you so much, ma'am.
Thank you, Pushpa madam. It was excellent talk. As usual, it's always pleasure to listen you. So now we are going towards our session of panel
Bala,
discussion.
can I intervene?
Yeah, please, please.
CTG was never explained so well. So thank you. Even I was listening to it late, early. She has really put a, really she has means it has it has hammered our brains. It has gone straight to the brain. So thank you, Dr. Pushpa. Yes. And also, Dr. Braj, I would like to wish you all the success in your coming elections.
Thank you, dear Pa ma'am.
Yes.
Thank you so much.
I-
Blessings
yes.
need that. I need blessings from all
Blessing,
of
you are the best.
Thank you so much. So we are moving towards our panel discussion, and for that we are having very, very sincere academician, Dr. Sneha Bhuyar. She doesn't need any introduction. She is always with academics and good topics. It is her brainchild of this webinar, Amog, Medical Disorder Committee, and particularly today's talk on panel on medical disorders in pregnancy, because there are many dilemmas, and we know her. She's having good academic record, awarded so many times, National Individual Award, National Award for SN Malhotra, Asia GCC Award, so many things. And we are having Galaxia panelists from Maharashtra, Dr. Gaurav Desai, and he's from Mumbai, endoscopic robotic surgeon. He's Amogs Managing Council member, and he had been Assistant Secretary, Foxy Journal Jogi, and speaker at Foxy programs, ICOZ, and so many awards, Rudra Sinha Award, CS Don, UA Foxy Awards, and he was Foxy FOG and SFOG Young Generation Award. So we welcome you, Dr. Gora. Next,
Thank you, madam.
Dr. Sunita Madhwani, and she's lovely friend from Ratlam. She's President Ratlam OBGY Society and doing so many good social and academic activity. So welcome you, Dr. Sunita.
Thank you, ma'am. Thank you, ma'am.
Next, Professor Dr. Mudita. Mudita is from Bhopal. She is professor at RKDF Medical College, past secretary Bhopal OBGY Society, and treasurer. She had been past joint secretary of Bhopal Menopause chapter. So welcome you, Dr. Mudita. Next one. Dr. Varsha Khandelwal is from Narmadapuram Society, and she is currently practicing since last 25 years, and Dhanraj Seth Memorial Hospital. She is trained in ultrasound and infertility, fellowship in laparoscopy, and currently she is present secretary of Narmadapuram OBGY Society. And you people are doing so many good activities we used to see in MPOG platform. Welcome, Dr. Varsha.
Hello,
Next.
madam.
Neha Seraf, she is ex-secretary Ratlam OBGY Society, always eager to join. For in short time, she can join anytime. So welcome you, Dr. Neha.
Thank you so much, ma'am.
And next one is Dr. Shikha Agrawal from Ratnam Society. She had fellowship in reproductive medicine and sonography from Indira Infertility. She has 4 publications in renowned journals, and she has worked in various hospitals in Delhi, and she has been associated with IVF, Indira IVF 2019. I welcome you, Dr. Shikha. So
Thank you, ma'am. Thank you so much.
I invite Dr. Sneha. Dr. Sneha. Yeah. Madam, over to you.
Thank you so much, Brush, for everything, I would say. Thank you so much. And without
Madam,
yes.
let's take a pledge, all of us. This time, Sneha Bhuyar ma'am is our winning candidate. So we all
Yes,
are
winning
there from
candidate from Vice
yes,
President.
three cheers for Sneha.
Definitely.
We have
Thank
to see
you
you
so
there.
much, my dear. Thank you so much for all your, love and affection. All of you.
Madam,
Yes. Hello.
one more minute. I would like to invite you all to Bhopal for Vice President Conference in July, 12th, 13th, and 14th July.
Thank you so much, my dear. Thank you so much. So without much ado, I think we should move on to our panel discussion also. We have so many good star panelists, I would say. So I will just share my screen, and our panelists have been already introduced, but it is my pleasure to welcome all of them: Dr. Gaurav Desai, Dr. Sunita Wadhwani, Dr. Mudita Jain, Dr. Varsha Khandelwal, Dr. Neha Saraf, and Dr. Shikha Khandelwal. Uh, I have been introduced twice, I think. So I just go ahead with the topic. Why are we discussing this medical disorder during pregnancy so often, and why we need to have discussions? So, friends, all of you know that pregnancy per se brings about profound physiological changes in our body, and that puts all our system on additional load, especially the cardiorespiratory and hematological system. So on top of that, if the woman has pre-existing comorbidity, some of the medical disorders, it poses the woman at an additional risk. So medical disorders of pregnancy like anemia, heart disease, hypertensive disorders of pregnancy, hyperglycemia in pregnancy, thyroid dysfunction, these are quite frequently encountered by all of us in our day-to-day practice. And in addition to this, even the hepatic disorders, various kinds of infections, febrile illnesses, these can pose the woman at an additional risk. So we now start with the most common, medical disorders of pregnancy, and we start with Dr. Gaurav Desai. So, Dr. Gaurav, we have this third gravida para 2 with 3 months amenorrhea. She comes to you with a history of weakness, easy fatigability, breathlessness, but there is no pain or bleeding. Her vitals are stable, and when you examine the abdomen, is soft, non-tender. Her investigations reveal that her hemoglobin is only 5 gram %. So, what is your clinical diagnosis at this point of time? Any differential diagnosis you have, and what investigations you would like to do for this patient?
Yeah, so thank you, madam, first of all, for the invitation. We see quite a few of these cases. I'm a faculty at KM Hospital, Mumbai, which is one of the nodal centers and a referral center for high-risk obstetric cases. So, before, when we have the clinical picture, if a patient comes with these symptoms, weakness, fatigability, breathlessness, obviously the hemoglobin takes some time to come. But there are some clues from examination that we can get. As far as symptoms are concerned, this could, one, be anemia, but one should not rule out other causes. For instance, even for example, diabetic ketoacidosis, breathlessness, say from cardiac disease, or fatigability from just vitamin D deficiency. There is a whole plethora of sort of differential diagnosis. Anemia, yes, it is one of the most common and one of the top causes. So I would, and now with the hemoglobin of 5 gram, yes, I mean the diagnosis is clear.
Obvious now. Okay. So how would you investigate? That is what Dr. Sunita, this is a question for you. We know that she has anemia, but how would you investigate her for knowing the severity as well as, the etiology of this?
Ma'am, for anemia, good afternoon, everybody. And thank you very much, ma'am, for taking me as a part of this esteemed panel. And I really extend my best of luck to you for your upcoming elections.
Thank you, my dear. Thank you so much.
The next, whenever the ANC patients come to us, ma'am, we usually do the CBC for those patients. And CBC is a picture which is by and large a very clear picture. Primarily you would know what is going on in that patient.
Yes.
In CBC, if the RBC is, the RBC count has to be seen, hematocrit has to be seen. If the hematocrit is low and the RBC count is low, and if hemoglobin is low, that itself says that patient has anemia. And for that, we'll go for serum electrophoresis and iron binding, total iron binding capacity, total ferritin level of the patient.
Right. Okay, so to know the severity, you have already, you have the hemoglobin report in your hand, but to know the severity, to what extent? the patient has severe, is it only the clinic? I mean, it's not that, suddenly all of a sudden she will have a hemoglobin 5. It has to come through various stages. So who will throw that? Dr. Mudita or somebody else? Does the woman develop a severe anemia all of a sudden, or there are various stages or phases of anemia?
Ma'am, patient doesn't develop severe anemia at such stage. There are definitely various stages where we had missed to diagnose anemia. She is para 2, live 2, so maybe in previous pregnancy, if there is short interval of pregnancy, she must have lost the blood and she is not able to recuperate. Or she is not able to take proper iron tablets, or she is intolerable to iron, so she must have skipped the iron tablets, so she has not recovered her hemoglobin. Now we don't do TIBC, we go for serum ferritin levels also. So the hemoglobin of this patient is 5 gram percentage, so she comes under very severe anemia according to the WHO criteria. Hello?
Yes, Mudita, you are audible.
Hello.
Yes.
Yes.
I thought I just lost it.
Yeah, no, you are very much there. So, what are the phases? In fact, I was little disconnected. What are the phases? What did you say? Just in short, what are the phases of anemia?
They're usually.
Yeah, let me. Yes, Dr. Varsha, please go ahead.
There are 3 phases in in first stage, iron stores are depleted, but RBCs are not affected. And in second one, the iron stores are depleted, but the RBCs are also affected. And third, in erythropoiesis is there, and third, anemia is definitely there due to iron deficiency in this.
Yes. So, what are the? Why should we know all this? Why should we know all this? That there are various phases. Hemoglobin is 5. We know that she's got severe anemia.
Hello.
Yes. Please go ahead first. Yeah. Why should we know all this, that the patient has so many phases and it's not only the clinical picture of anemia? What is the logic behind knowing whether she has iron stores depleted or no? It's only her serum iron level is low. What is all this? Yeah.
If a pre-pregnancy level of iron, hemoglobin is very low, then there will be less hemoglobin for the synthesis of new RBCs. So pre-pregnancy hemoglobin level should be in a proper level before she conceives, so that severe form of anemia is not developed.
Okay.
Yeah.
Madam, I would like to add.
Yes, please.
Ma'am, in the first stage, iron stores are depleted. So where iron responsible for making new hemoglobin is less, and RBCs is dwindling, so it doesn't affect RBCs. So second stage, the iron stores are low.
Okay.
So for that, the normal process of making RBCs altered, so our hemoglobin comes out to be low. And third is the compulsory
The serum iron, you meant to say. The serum iron level.
Yes. Serum iron level is low. And in the third stage, anemia.
Yes. Okay. So let us go ahead. How will you manage, Dr. Mudita? Suppose patient you have investigated that, she turns out to be iron deficiency anemia, and her hemoglobin level is 5 gram % during early pregnancy. So how would you manage?
Ma'am, for this patient, I would like to do deworming also, and for less than 5 grams, she comes under severe
we talk about
anemia.
the anemia first. We talk about the
for this patient, I would like to do blood transfusion
first, and then the general supportive management later. Okay.
For this patient, ma'am, blood transfusion is the first ideal management.
Yes.
So we will go for blood transfusion of this patient.
Hemoglobin level of less than 5 gram % anytime during pregnancy is an indication for blood transfusion. Okay. Suppose she is not willing, or maybe, people have differences of opinion here. If she is if she was not symptomatic, we could have had an option for going for injectable iron. But this patient is symptomatic. Okay, so we definitely have only blood transfusion as a treatment of choice. Suppose this patient was asymptomatic, and then what was your choice also, or some option you can give to the patient?
Ma'am, if she's asymptomatic and she doesn't want her blood transfusion to be done, then we can go for IV FCM for the patient.
Mm-hmm.
And
So how much
so,
FCM you would give? How do you calculate?
ma'am, we calculate according to her deficit, total target required according to minus actual hemoglobin level, which is the
Right.
deficit of the hemoglobin, into 2.4 with pregnancy weight, into pregnancy weight.
Yes.
Which come out
Plus,
to be the calculated amount of requirement.
yes, and plus 1000 milligram, that is to replenish the iron stores. Okay. Okay.
Yes.
So we have done with the phases of iron. So now I would just ask you, why are we worried so much about this anemia? What are the effects of anemia on pregnancy and pregnancy on anemia? Anybody can take up this question.
Effects of anemia in pregnancy, the patients may have preterm births.
Yes.
Then PPH, then maternal mortality rate is also increased. The
IUGR
baby might
is also there. IUGR is called for babies.
IUGR will also be there. Then in cases like in twin pregnancies, also.
Right. Okay, but what is the effect of pregnancy on anemia? Does it exacerbate it? Does it
pregnancy
exacerbates it.
Yes, so Gaurav, can you just throw some light on why is it so? Why there is a physiological hemodilution? And why pregnancy worsens the pre-existing anemia?
So number one, the fetus is a parasite. It will take up whatever it needs, whether it is hormones, whether it is iron, any nutrition it tries to suck out from the mother. The second is physiologically in pregnancy, there is an increase in plasma volume. So as the gestational age goes on, there will be a rise in plasma volume compared to what the iron stores are. So you will net, it will be an anemic state. So the iron supplementation has to be given to a pregnant woman. With regards to actually the question before, where you regarding the stages of this thing, one of the important things is also response to therapy. You need to know the stages to find out, gives a hint to the cause of anemia as well as the response to therapy.
Yes.
Yeah. And of course, regarding the complications, there are many complications. It's divided into either antepartum, intrapartum, and postpartum. The important ones, antepartum in the first or second trimester could be either an abortion, could be an intrauterine fetal death in case of severe anemia. We've seen any hemorrhage at this stage can result in catastrophic maternal morbidity and mortality. Infection is another cause, puerperal sepsis. These are all failure of lactation also are all included in this anemia.
Right. So right from the higher incidence of preterm labor, okay?
Yeah.
Preterm labor, maybe the labor dysfunctions, prolonged obstructed labor, and then higher incidence of operative intervention, again predisposing to PPH and puerperal sepsis, and as you have rightly pointed out, even the lactation failure. In between this, you may definitely have the fetal growth restriction, fetal distress, and of course the other complication. I'm sure all of you have heard about anemia toxemia syndrome. Usually there is an association of hypertensive disorders, and of course these women are more prone for the abrupt show placenta. The reason being maybe just the folate deficiency, right? So all this add together to the morbidity and mortality of the mother as well. So rather than have, should we just screen this? SCOG says that every pregnant woman during pregnancy should be screened. But should we screen these women only during pregnancy, or should we screen them before? Because anemia is so rampant in India, more than 50% is the incidence. So what should be the screening strategy? Yes.
Ma'am, it is always a better idea to screen the women in the pre-pregnancy state so that we can correct all these deficiencies. And then when the patient conceives, she has to go through lesser side effects and lesser morbidities during her pregnancy. Her pregnancy actually becomes a happier one.
Yes.
when she's not
And
efficient.
during pregnancy, when do you recommend the hemoglobin estimation? Is it only at the first visit or how frequently, according to Government of India guidelines?
Ma'am, at the first visit, and basically it should go 4 weekly.
Mm-hmm. Hello.
But 4 weekly is usually not possible in all
Every
the
trimester,
with
ma'am.
all the patients.
Every trimester, right?
Once in all the trimesters.
Correct. So the
Every
recommended
trimester,
visits.
once you have to do it in every trimester, ma'am.
Hello, who is that? May I know? Can you please specify? So it is at the first visit? Yes, yes, Sunita, you can talk about it. You want to say something?
Ma'am, not audible. You were not audible.
Hello?
Now we can hear you, ma'am.
Okay, okay. So at the first visit, 16 to 20, 24 to 28, and 34 to 36. That's it. So naturally, we say ideally just before conception, as Neha has said it, that you optimize her hemoglobin level as you optimize all her conditions. That is what is pre-conception counseling and evaluation. Otherwise, when you have so much of rampant anemia, even preconception and premarital, because we have various hemoglobinopathies also, which are very, very common. So with this, I think we will not discuss much the management aspect in the later pregnancy. We take up this second case now, Dr. Shikha, for you, Shikha Khandelwal. So we have this unregistered primary gravida, married for 2 years, and she comes to you with 9 months amenorrhea. She comes to you with pain in abdomen, discharge per vagina, mild fever, cough, breathlessness. She has tachycardia, no pedal edema. So she was having mild pains, but suddenly she gets spontaneous rupture of membrane. So thinking that, this is just getting a protracted labor. So she was augmented with oxytocin, but she landed up into fetal distress. Now she was taken for LSS. The anesthetist examined, found a murmur there. Okay, so she was given a regional anesthesia, baby delivered, and suddenly she started getting breathlessness. What is your diagnosis here? What is the exact etiology and how do you classify and manage, I would say?
Ma'am, it is very evident here that she's a case of mitral stenosis, a cardiac case of probably mitral stenosis, because the anesthetist has already got a diastolic murmur. She's an unregistered primary, so we can assume she belongs to a very low socioeconomic status. So it is most probably rheumatic heart disease, and it might be infective also. She might have already landed up in infective endocarditis. Because she is already having fever and
cough and all this.
Yes, ma'am.
Yeah.
And ma'am, regarding classification, we know that we generally one is this NYHA classification in which we classify all the cardiac diseases. Yes, ma'am.
Yes.
Grade 1, grade 2, grade 3, and grade 4, in which grade 1 is there is no limitation of activity, grade 2 is there is mild limitation. Grade 3, there will be marked limitation of physical activity, and grade 4 is severe limitation. Basically, symptoms are at rest.
Okay.
And if we classify according to the other thing, that is, it may be rheumatic heart disease or it may be congenital heart disease.
Yes.
Yes, ma'am. Etiological classification. So congenital will be we will classify cyanotic heart diseases or non-cyanotic heart diseases. Cyanotic, definitely we do not want the patient to be pregnant, but if as this patient, she has come already, she is pregnant, so it will be a problem. Then congenital will be non-cyanotic, will be atrial septal defects, ventricle septal defects, pulmonary stenosis, coarctation of aorta. Cyanotic will be Fallot's teratology and Eisenmenger's. And rheumatic, we know, which is stenosis, which is most common. Mitral regurgitation, which will be a other complication.
But then what is more common nowadays coming up? The cardiomyopathies.
Cardiomyopathy, ma'am, especially after COVID, it is dilated cardiomyopathy we are getting.
Dilatation cardiomyopathy is becoming very, very common. And even, these cyanotic heart diseases or the congenital heart diseases, which were not reaching this obstetric age, because of the corrective surgery, these women are also reaching to this age where they can they do conceive, where actually maybe before correction, they're not allowed to conceive. But then because of the corrective surgery, they are allowed to conceive. So, but then you have to take certain precautions. So you have this patient who's got rheumatic heart disease, mitral stenosis on priority, and NYHA grade, I think 2 or 3.
Yes, ma'am.
Yeah. The
Yes,
aggravating
ma'am.
factors, you know that you have already said that she has some element of infection and she's in labor pains, and she's also augmented with oxytocin and IV pills. So all in all, they're adding to the problem. So what are the poor prognostic indicators, Dr. Gaurav? And how will you tackle it?
Yeah, so first of all, when we look, of course, we get a cardiologist to also opine on this, but a low ejection fraction, less than 40%, would be a poor prognostic indicator. A murmur or any other electrophysiological abnormality would be the second if she has associated cardiomyopathy or muscular disease or the cardiac muscle. Any other comorbidity like anemia or thyroid issues might also super added onto this, because we see these, we don't just see cardiac disease by itself. Sometimes there are other comorbidities associated. Renal impairment, if kidneys are affected, if there is cardiac failure involved, these are all poor prognostic indicators. Arrhythmias are another poor prognostic indicator.
So baseline NYHA class 3 and 4, these are very high risk cases, okay? And if you do her echocardiography, the mitral valve area of less than 1.5, what we label it as critical mitral stenosis, right? Ejection fraction, you have already said, if it is less than 40%, and Eisenmengerization. Eisenmengerization, and you have the reversal option and primary pulmonary hypertension. So these are the ones you actually advise them against conception, right? So what are the aggravating factors, Dr. Sunita?
Ma'am, in pregnancy, whenever the patient goes into labor, it is an aggravating factor because it is the anxiety of the patient and the pain. If she has associated factors in the form of age, extremes of age. If she's very small, below 18 years, or maybe she's an elderly, then she would have associated risk with that. Anemia, infection, hypertension, then physical labor, whatever, if exerting work she's doing. Then weight gain again during the first trimester is a very important factor. If she gains too much of weight during her pregnancy, then she'll have exaggeration of her cardiac symptoms. Then multiple pregnancy, if she's a smoker, caffeine or alcohol is consumed, pain, and drugs in the form of prophylactics are always against cardiac thing.
Yes.
And one more thing I'd like to add to this, ma'am. Here in Ratlam, most of the gynecologists here, we are doing a screening 2D echo for all the patients at 32 weeks. My husband is
even Tamil Nadu government has made it mandatory.
And to be very it is very surprising that we really come across too many cardiac heart disease cases these days. And particularly the dilated cardiomyopathies leads the team.
Okay. So once again, Mudita, I will ask you, how does heart disease affect the pregnancy, and how does pregnancy affect the heart disease? Dr. Mudita? Do we have Dr. Mudita? Anybody can take up this question. Dr. Braj, can we request you, all the panelists to put on your video, please?
Okay. Mudita. Hi, Dr. Mudita.
I think Dr. Gaurav can take up, and Dr. Sunita
Sunita is there. Dr. Gaurav is there.
Yeah.
Yeah, so there is, of course, increased stress on the heart. There is an increase in preload, increase in afterload. The heart is not just pumping for the woman, the heart is pumping for two people, that's the woman and the fetus. So the heart needs to pump more. If there is any sort of obstruction, any sort of change in anatomy or a heart disease, that sort of poses an increased stress on the heart as well as the vasculature. So there will be a reduced or any altered blood. Maybe if it is in case of a cyanotic heart disease, there will be deoxygenated blood, which is not ideal, which is reaching the fetus and even the mother, the other vital organs. So that puts an additional stress. And if there is an insult to any other organ or the fetus, then it sort of is a sort of a vicious cycle where the body demands better and more blood, and the heart cannot eventually provide that. So eventually it goes into cardiac failure and affects the kidneys.
Yes. So worsening of the cardiac status, as Dr. Gaurav has rightly pointed out, and of course the mother can land up into CCF, bacterial endocarditis, pulmonary edema, pulmonary embolism, rupture of the existing embolism, and of course long-term basic defect also. There is no effect. But on pregnancy, definitely you can have, right from early pregnancy, you can have spontaneous abortions, preterm labor, FGR, and the baby may have congenital heart disease in almost 5% of cases. Of course, as we said, if it is a very high risk cardiac disease, then there are chances for deoxygenated blood going to the fetus, and of course the fetus landing up into problems and fetal demise also. So basically we should have the high index of suspicion. Every obstetrician also make it a point to put your stethoscope on the chest of the patient, at least auscultate the chest at the first visit, and maybe at least once in every trimester. I would say every time you should auscultate, but timely diagnosis and effective management. Definitely, if you diagnose, then you have to evaluate, refer to the appropriate person. But if at all you have this, then you need a multidisciplinary team with you to manage such kind of patient, including obstetrician. You may have you may get a senior obstetrician, anesthetist team, cardiologist, neonatologist, and of course the cardiothoracic surgeon, and a very good expert nursing staff as well. So, Doctor, do we have our panelists here? Dr. Varsha, Dr. Shikha?
Yeah, madam.
Yes.
Yes, ma'am. Yes, ma'am.
Yeah. So, can you throw some light on all these aspects? How would you take care of this? We have already discussed, actually, we could not see you. So, yes, any message?
During labor, like we'll have to put the patient on monitor. Then oxygen also should be started, what we do for all the patients. Then monitor also for the patient. Then though IV fluids we'll have to give. Then we have to reduce the second stage of labor. Nowadays, ventus and forceps, if everyone is using.
Cut short the second stage of labor.
Shorter second stage.
Yes.
Then
and what about oxytocin?
Like methargine should not be given, pitocin should not be given.
No methargine. Okay. What is the oxytocin of choice and how will you give it?
Carbetocin now we can give.
Yes.
Yeah.
And suppose you need to give oxytocin, then how will you prefer? Should be a constant infusion.
Bolus should be avoided.
Bolus should never be given.
Never be
avoided.
Bolus should never be given. It leads to hypotension. It will worsen the cardiac status of the patient.
Antidiuretic effect also.
The myocardial ischemia also can result because of hypotension. Okay, so for such patient, definitely we need to have the preconception counseling and evaluation to prevent the mishap that we have already talked about, that we have to scrutinize them and we have to manage them, optimize their condition, cardiac status before we allow them to conceive. Now, Dr. Neha, do we have Dr. Neha here?
Yes, ma'am. Hello,
yes. So Neha, we don't want to lose you. Be here, please. We want to hear from you. Yeah. So we have this 22-year-old primary gravida coming for the first antenatal checkup at 10 weeks. On examination, she is 152 centimeter tall, 69 kg BMI. She does not have any family history of diabetes. Okay. Now, actually, this is, I would take you that actually we had such cases. You must have heard from Dr. Geeta also. Now she has included this case, which actually my original presentation has this case, that you get a patient who is, very much in prolonged labor, and that is because of the large size baby. You just heard that case, 4 kg baby. So that is a case which actually we have managed. So whether you want to screen this patient, if yes, why, how, can you just start discussing this?
Yes, for sure. I would like to screen this patient. There is such a universal screening of diabetes is mandatory.
Yes. So the
And
only message I want to give through you from this, for this case, I will ask you to discuss and continue further. It's not because her BMI is high. It's not because she's priming. It's not because she is obese, or it's not because she has PCOS. It is not high risk screening nowadays. It is a universal screening. That means every woman during every pregnancy should be screened, and that is by single step OGST. Go ahead, please. What screening tool? How will you do? How are you doing this? This is what I have already talked about. So how do you do the OGTT?
75 gram glucose and 100 ml of water is to be taken orally. And then 2 hours post this oral glucose, we'll test for her blood sugar level.
Okay. How do you interpret it?
Ma'am, blood sugar level after 2 hours, if it is more than 180, it is
140 milligram%. 140.
Yes.
हेलो सुषमा, मैंने तुमको एक शेयर किया है, तुम भी रजिस्टर्ड कर लो, तुम्हारे
Hello,
स्टूडेंट से भी
Braj,
करा
you
लो
need to
रजिस्टर्ड
mute yourself, please.
कल के वेबिनार के लिए, वेबिनार के लिए।
अच्छा, Sahiti, can we mute Dr. Braj?
कर ही लेना अभी।
ड्राइव कर रही हूँ।
ठीक है।
ठीक है काय पर है?
साहिती,
वो पेरीनेटल आउटकम पे है, टॉर्च है,
ठीक
और मैटरनल सेप्सिस।
हेलो,
अच्छे टॉपिक है, अच्छे टॉपिक है।
अरे
रजिस्ट्रेशन कर लो।
टाइमिंग क्या है?
4 to 6।
ठीक है,
रजिस्टर्ड कर लो, टाइम मिले तो ज्वाइन कर लेना, है ना?
मैम रोज वेबिनार करेंगे, थक जाएंगे।
ठीक, हम भी कर रहे हैं।
So we go ahead with the discussion. Why are we worried so much about this hyperglycemia, Dr. Neha?
Ma'am, hyperglycemia is going to have hazardous effects both on the mother and the fetus. On the mother, the medical condition and the pregnancy is going to be affected. The fetus will have macrosomia. The fetus can have congenital birth defects. So we have to take care of, we have to keep a controlled blood sugar level so that we can manage both the fetus and the mother well, and the pregnancy goes uneventful.
Right. So it is not only the fetus.
नाम ब्रिजबाला तिवारी बात कर मैम इंदौर से।
अरे बाप रे।
Actually.
Sahiti, are you around? Otherwise, I will.
लगा रहे हैं, मैम उनको फोन लगा रहे हैं।
हाँ, तो लगा दो. So yeah, Neha. So we can go ahead with the discussion. You have this, higher perinatal morbidity as well as mortality, because right from spontaneous abortion, congenital malformation, preterm birth, FGR or macrosomia, you have, and all sorts of operative interventions and trauma during delivery for the baby. And for the mother, what did you say, Neha?
Okay, ma'am.
Ma'am, gestational diabetes will lead to nephropathy, retinopathy, vasculopathies, preeclampsia.
Yes.
All the hypertensive disorders of pregnancy. And then difficult delivery will lead to instrumental delivery, higher rate of cesarean sections.
Correct. So,
increased risk of infection.
Right. So the universal screening is the consensus by every organization, FOXY, FIGO, NHM, Government of India, Family Welfare. Okay. So should we use HbA1c for screening of GDM? That is the question. Neha,
No, ma'am, actually,
yes,
ma'am, we should use HbA1c because, ma'am, in first trimester, like she's in 10 weeks, she's 10 weeks right now. Or if the patient comes earlier. So first of all, if we do HbA1c, we know whether she is an over diabetic or if she and if the HbA1c level is normal, then we know that if she develops high sugars later in pregnancy, we know it is GDM.
So you yourself has answered the question. In fact, HbA1c you can be used only for prognosis and not for diagnosis. Okay, so it is
Diagnosis.
not
Yes,
to be
ma'am.
used for screening, but it is
Yes,
to
ma'am.
be used for prognosis. You have to know
Prognosis.
the sugar levels over last 3 months, and then accordingly, what is the prognosis or outcome of this pregnancy. So for screening, it is single step 75 gram OGTT. So now, Dr. Shikha, does this HbA1c, does it correlate well with the blood glucose levels?
Yes, ma'am, it does correlate, ma'am. If the blood sugar levels are high, we will get a high HbA1c level.
Yes,
And
but
in
blood
fact, if
sugar levels are
HbA1c
high at some point of time, at the other point of day, it is different. Okay, so it tells you the average blood sugar over last 3 months.
3
Right?
months.
Not,
Yes,
it
ma'am.
doesn't correlate well with the levels of blood glucose on that particular time, right?
Yes.
So,
Yes, ma'am.
what is the correlation of HbA1c with
Yes,
congenital
ma'am.
malformations?
Ma'am,
Yes.
if the HbA1c level is less, that it is less than 6.5, 6.7, then we know that the rate of cardiac malformations or rate of congenital malformations are very less. If HbA1c level is more than 10, then actually the rate of malformation increases and it might be more than 30%. And in fact, in some studies, they are saying even 50% if it is more than 12. So if the patient is in early pregnancy and we get a very high HbA1c level, we can even suggest termination of pregnancy.
No, my dear, that is what the message we want to give, that let the patient decide. You are right. Up to this point, you are right. Only the last sentence we want to just correct it, that you have to explain them that because this HbA1c is so high and the incidence of congenital malformation because of this is so high, you may think twice or you may revise your decision that whether you want to continue with the but you do not advise MTP or termination of pregnancy for anybody for that matter. Okay, because that becomes a medical legal issue. Okay, so you just help them making the informed decision. That is what it is. Okay, so here also this is one more point, that the blood sugar levels correlate very well with the perinatal mortality. You can see in this chart, if the levels are more than 200, the perinatal mortality is to the tune of almost 35%. And if the blood sugar levels are less than 100, see, it is less than 4%. Okay, so we have to suggest them that these women need to bring out their blood sugar levels at very well. Then they need to go for stark necessity of the blood sugar control. And why this why is it necessary? Because they correlate directly with the perinatal morbidity. We have to make sure that these women are euglycemic, they achieve their target levels, that is 65 to 90, and of course 90 to 105 post meal 120. So that likewise we have to optimize the level. So we have already discussed this, how to screen and how to interpret. So suppose you have a patient who is now, you have done her OGTT and she is screen positive. Dr. Sunita, this is a question for you. So she's, hello, Dr. Sunita?
I'm there.
Yes. So you have this patient who is GDM positive, the screen is positive. So how would you, how do you do it normally, routinely, how do you advise this patient?
If the patient is positive, if the patient is GDM positive, if we find that patient's GTT is bad or DIPSI test is bad, we opt for a HbA1c, and if we find it is raised, then we'll put her into the category of GDM. And after putting her, what we would do is we'll initially try to manage her on.
No, I did not understand what is the role of HbA1c here. Your GTT, OGTT is positive. That is why you have labeled her as GDM. Now, how do you go ahead? So you will not do her HbA1c to manage her. First, you will do her HbA1c, see that whether she is really a case of over diabetes. That is okay. But if she is purely GDM, that means her HbA1c is within normal limit. Then how will you go ahead?
We will try to manage her on medical nutrition therapy and monitor her regularly. And if her postprandial, 2 hours postprandial blood glucose turns out to be less than 120, then we'll keep on monitoring her every 2 weeks. Before 28 weeks, if the patient is less than 28 weeks, then we'll do the PP BS, that is postprandial blood sugar level, every 2 weeks. And if she is more than 28 weeks, we would be doing it every week. In the same way, if the postprandial blood sugar level of the patient is more than 120, then we'll stop. I mean, we'll continue with the medical nutrition therapy and we'll add insulin to it. And we monitor the patient's FBS and PPBS in that case.
Is it a stringent criteria that you will start with insulin, or you have some options?
Think of metformin also.
So insulin is the drug of choice, but you have two options.
Definitely, ma'am.
We will come to the evidence, what the evidence says. Okay. So you are advising a nutrition modification, diet modification, and physical exercise to this lady for 2 weeks. Then you are calling her back and you are doing her 2 hours postprandial blood sugar levels. If it is less than 120, you are happy that you will ask her to continue with the same. If it is not controlled, or it is more than 120, then you will add medication to this. Okay. So now you are talking about MNT. So what is MNT and how do you advise your patient? She asked me, she asked you, madam, how many calories I should consume? What is my requirement? Then how do you decide that?
Madam, we decide according.
Yes, Mudita.
Ma'am, we decide according to BMI, and if she has gained around 5 kg of weight, then her calorie requirement would be less than around 30. Total around will be around 1600 calories per day.
Okay. So how you tell me how much weight gain do you allow if she is undernourished, underweight, or if she is having optimum BMI, or if she is having high BMI? How many kilos you allow her to gain?
Ma'am, if she is over BMI, her BMI is more than around 20-25, then we allow her around 5 kg weight gain. If she is underweight, her BMI is less than 19 BMI kilogram per, then we allow her around 6 to 7 kg of weight gain.
What is the average weight gain you allow for normal pregnancy?
Around 10 to 12.
Yes. So at least 10 to 12. And if she is
10 to 12.
If she is underweight?
She is underweight, then 12 to around 12 plus 4-5 kg, 16 to 17.
That's what I'm saying. It should be little higher. No, not 5, 6.
12, ma'am, 12 plus 5. 12 plus 5, I want to say that.
Okay, okay. So if she is obese, then only you have a weight restriction of 5 to 9. Okay. And then how do you decide that? You decide that on the patient's baseline weight, gestational weight, that is, and the level of activity. Okay. The level of activity. If her working is sedentary work, then it's only 1900 plus 350. If it is moderate work, then 2200. This is for an average weight lady. Okay. For an average weight lady, the allowed calories is 1900 plus 350, 2200 plus 350, and 2800 plus 350 for a woman who is working heavily. She's doing strenuous work. Okay. So the gestational weight is the one which is the guiding criteria. Gestational weight and the level of activity. These are the two parameters to be considered. Okay. So you have already talked about this MNT. And if at all it is not controlled, then you can go for medication. Now, what medication, Dr. Mudita? How would you decide that whether insulin or metformin? And how do you do that?
Ma'am, preferably we start with metformin, but if required, we can add on insulin in between. We can give around 2000 milligram of metformin for a patient, and we usually do 7-point charting of the patient
for metformin,
in initial weeks.
For metformin?
For metformin also, madam, for initial 2 to 3 weeks, we do 7-point charting in a week. 7-point charting in a week means like
we are talking about a 7-point testing for insulin in a day, right?
No. We are talking about 7-point charting of blood sugar in a week.
Okay.
So for that, we don't have
that. How do you do that?
Okay. Ma'am, for that, we do fasting in a day. Then after breakfast 2 hours on Monday, then Suppose we started charting
Achha,
from
daily
Sunday.
you want to do one fasting and the next day post.
Then
Okay, okay.
postprandial we do
You
like
are
that.
trying to use the permutation combinations of
Yes,
fasting.
yes, yes,
Okay,
yes.
okay, good.
So we
Okay.
get a whole week criteria for that. Ki what are our sugars for the per meal, after a meal,
Okay.
post breakfast, post lunch, post dinner. Even we ask them to do at 2 a.m.
Late,
for
yes, very late night. Correct.
very
You're
late
right.
night.
Mhm.
So for after that, we usually see that if our sugars are levels are normal and only fasting is add up, we add up metformin in the night, dose is increased. If not, it's like her fasting is coming more than 120, then we add insulin for that.
Okay.
Otherwise, we prefer metformin.
Okay. Okay. So, my dear, what are your criteria to start insulin directly? Directly, without suppose MNT you have done and she's not responding well, more than 120 postprandial. So you have two options, metformin and insulin. But then what is your criteria to start with the insulin directly? Yes? It is very easy. All of you have said that.
High blood sugars, ma'am.
Okay, blood sugar more than 200 at diagnosis. Okay, very simple.
Yes.
But you can keep your say that yes, no, insulin is the drug of choice. I will start insulin only because my patient is good socioeconomic status. She can afford to have diet counseling and she can afford to go for 7-point testing of insulin. Okay,
We
because when
prefer
you start
insulin only, madam. We don't give metformin.
Yes.
Like it
Yeah.
crosses placental barrier also, and insulin has very effective control. So we prefer only insulin.
Okay.
Ma'am, for educated class, we can start insulin directly, but for non-educated class, to teach them how to take insulin is very difficult. Even we train also.
Nowadays, everyone is quite educated to do
No,
the
no,
sugar.
madam. No,
No,
madam.
no,
We work
Dr.
at tertiary center.
Yeah, yeah.
It's
So
not like that.
I need to interfere here. Mudita, you are very right that educated, you yourself has answered that educated, compliant women who have got all the facilities for counseling, diet modification and testing. They should go for insulin because insulin is the first drug of choice, right? Now, Dr. Varsha, this is a slide for you. That is why I have purposefully posted it here. That definitely this, it requires a very good antenatal care with a healthcare provider who is very, very well versed with the follow-up testing. And of course, you should have a good counselor even for the diet. You should have a nursing staff or paramedical staff who is very trained with all these things. Okay. But what it is recommended that management should be in accordance with the available national resources and infrastructure, even if when the specific diagnostic and treatment protocols are not supported by high quality of evidence, as this is preferable to no care at all. If you have, these village women who are saying even today, it is not true that everybody is educated. Even today, 80% of India's population stays in village. Even today, we have villages where there are no transport facilities. And even today, even I am facing this problem that even today, we have villages where there is nobody, no doctor to prick that injection. So we have to train them. That is the next thing. But you can train them pricking the injection. But how you will train them all these symptoms and signs of hypoglycemia? And why do you want to take the risk of their life as well? Correct? So for such women, even the evidence says that it is something is better than nothing. If these women cannot, they are not suitable for insulin, you can very well start metformin. And the evidence also says that there is one more slide showing that even Government of India and Ministry of Family and Health Welfare says that metformin and insulin, they are equally effective and safe to be used during gestational. See, this is the slide. Okay, metformin and insulin therapy, there is accepted medical management of pregnant women with GTM, not controlled on MNT. Insulin is the first drug of choice and metformin can be considered after 20 weeks of gestation. Correct? So this is the evidence. So our own guidelines, they are protecting us. So we should use it. After 20 weeks, absolutely no thoughts to be given. You can definitely use metformin. Before 20 weeks, yes, there is a dilemma. And that also you have to overcome. But that also, see, there are so many women who are having PCOS and they are continuing on metformin and they conceive and they continue with metformin, correct? So is it that metformin, there are very high risk for congenital malformation? No, evidence doesn't support this, correct? So we can definitely use metformin. So we conclude this case here. And now we come to you, Dr. Varsha. This is, I think this we will take it as a last case, I suppose. Okay. Yeah. So we have this 36-year-old lady, previous one cesarean section, now 26 weeks pregnancy, diagnosed diabetic during 3rd month, and she's already on insulin. Her HbA1c is 6.5, BP is 150/90, and clinically, small for gestational age is suspected. How do you manage this pregnancy?
Like her BP is 150/90.
What is
So
your diagnosis here?
what?
What is your diagnosis for this case? Clinical history examination.
Clinically, it is small for instance, she may be IUGR also, and BP is 150/90. So borderline hypertension.
Diagnosis. What is the diagnosis?
She's second gravida with midterm pregnancy with
elderly gravida. Elderly, 36 years.
Elderly gravida, second gravida.
Right.
With 26 weeks pregnancy with gestational diabetes mellitus.
No, diabetic. She's over-diagnosed.
Yeah.
She's
With
diabetic during 3rd month. She's already on insulin.
She was diagnosed during 3rd month. She would be gestational.
Yeah, but then the very fact that she is on insulin during 3rd trimester, it means her sugar levels may be more than 200, and that is why she's put on insulin straight away.
Okay. And again, she has PIH. She has PIH also.
Hypertensive disorders. Correct.
And the small for gestational age.
Which is leading to small for gestational age babies.
Right. So what are the risk factors in this patient? All this, what we talked about just now. Now, how do you, because it is only 3rd month, no? Okay. So
no, it is,
I think 26 weeks now. She was diagnosed diabetic during 3rd month, but now it is 26 weeks, already hypertensive and already FGR. So how do you manage this pregnancy? How do you take this pregnancy?
Doppler should be done. Strict diabetic management.
Who is taking this case, Dr. Varsha? Yes, please discuss.
Like Doppler, ultrasound, color Doppler, we should do at 26
For the investigations for the mother, for the baby.
For the mother, as already diabetic management we have done, and she is having mild pH. So all the kidney
investigations you want to do for her.
LFT, RF,
urine albumin profile, kidney profile, urine albumin. Then
she's
platelet.
very prone for diabetic nephropathy, retinopathy, and
yes.
Serum electrolytes also we have to do.
Yes.
For during
maintain our hydration.
baseline serum electrolytes also.
Yes.
Ma'am, firstly, we'll start with all the basic investigations that we do for every pregnant patient.
Yes.
The CBC, the viral markers, her thyroid profile, and OGTT.
Yes.
And then
all this.
Eco also we should be doing for her, because she would be again at high risk if she has some added component related to her cardiac element.
Yes. For the baby, what do you want to do? Right.
So
for
all
baby,
the markers.
Uterine Doppler study, 1st trimester Doppler study, the anomaly scan, and the fetal echo.
Yes. So if this was done for this patient, actually she would not have developed the hypertension so early. The obstetrician could have added low dose aspirin and high dose calcium. Okay, at the earliest. Correct. So
yes, ma'am.
This is the early onset toxemia or early onset hypertensive disorders of pregnancy. 26 weeks, she's having hypertensive disorder. Correct. Now, all these things should have been done. That is what it is written actually. Now you have to go for target scan and you have to rule out congenital malformation, congenital anomalies. Especially the cardiac anomalies, they are very, very high for these patients. Okay. Okay, right? Also,
Yes. Yes.
she's a case of previous seizure. Don't forget. Don't focus on diabetes. Don't forget. She's our patient. We have
Always plan her delivery in tertiary centers where the facility for
yeah, but
NICU
let us take
and
her
the
ahead. Let us take her ahead first. That we
Yes.
have to rule out the morbidly adherent placenta, right?
Yes,
Yes,
ma'am.
madam.
Okay. And then for this hypertension, would you like to start antihypertensive?
Yes,
Yes,
ma'am.
madam.
Yes,
Ma'am, not for
definitely.
150, 190.
No,
She
no,
can
my
focus
dear.
on
Who is differing? Please let me know, Mudita.
And we
Ma'am,
again
Madam, I will start antihypertensive.
Huh?
I will start
Ma'am, she
antihypertensive
might
as
be
well as
obese. She is
equal.
diabetic. She's on insulin. So might be 150, 90.
What is the
No, no. We
now?
should
Okay,
again
okay. Let us discuss
check
when
her
should we start
levels.
antihypertensive. Yes,
No,
Shikha.
ma'am, I'll start antihypertensive as well as ecosprin also.
Yes, ecosprin has to be started. That is what I'm saying. It was missing. But then when should we start antihypertensives? There is a difference of opinion I can see in the panel. That is why I have repeated this question. Dr. Shikha, I want to know from you.
Ma'am, actually, I feel ki she must be having high BMI, ma'am. So, because she's
We're talking about
diabetic.
hypertension only. When
Yes, ma'am.
should we stop?
Maybe like we are measuring this BP, ma'am. It's 150, 90. It might be because of deranged readings. So, I think I would
What is
like to
the
first.
ideal way to
She's
take blood
having.
pressure? Let us go to that.
Actually, we should be admitting this patient and we
Yes,
should
ma'am. I'm
monitor her
monitoring.
for around 12 24 hours so that we know that whether she's actually hypertensive or not.
Okay,
Ma'am, in
that is the
current
reason
cases,
I have
I would
that is the reason I have asked all of you one single question. How should you label the patient as hypertensive? When should you label the patient as hypertensive? In other words, how should you take the blood pressure in an ideal way? Okay.
Ma'am, BP more than 140 by 90. I
Immediate 2 or
start
3 days.
antihypertensive
Yes.
and I measure BP with the patient in supine position.
It should be in
With
a
the
sitting position, my dear. Now we are changing that. There are some
Changing that.
teaching concepts. Okay.
Ma'am,
So
in fact, I would like to take BP of both the hands also because
that is
now we are
what,
treating patients of
yes,
aortic.
that's the reason, Mudita, I want you to speak. You're right.
Yeah.
So the blood pressure has to be, see, the moment you measure 140/90, you don't label the patient as hypertensive. Wait for another 5 minutes. You say, tell her that, okay, don't worry, you have just come traveling. Relax. Don't get scared of me. Wait for 5 minutes. You take her blood pressure again. But then that means you have to see that she's physically and mentally at rest. Her clothings are comfortable. The BP size, cuff size. You have huge obese patient and you
Yes,
have
ma'am.
such a small cuff, so appropriate cuff size. Okay.
Yes,
And then the patient has to be in sitting position. And then you take it mainly on the right upper arm, but then both the arms and you will compare. Okay. Now, once you have this, so initial measurement, 5 to 10 minutes after relaxation, even if that is same, then after 4 hours. So meanwhile, you advise her the investigations to see whether this is just a transient rise in blood pressure or you really have effects on the, liver, spleen, liver, kidney, all these things. Okay. So you send her lab investigations, LFTs, KFTs, CBC, hematocrit, whatever. Okay. Now, these two things are different. Here on this investigation, you are trying to assess the end organ damage. Okay. Whether she has end organ damage. But here on this side, you have that this patient is labeled as hypertensive. So 140/90, whether you should start antihypertensive. Now the question still remains the same. Okay. So why you are confused, I'm telling you. A decade ago, there was a concept that, NICE NHS 2010 guidelines, they said that you should start antihypertensives only when the blood pressure goes above 150, 100, right? Systolic 150, diastolic 100. But this doesn't hold anymore true because I'm sure majority of you must have also observed or witnessed that your patient on 140/90 suddenly convulses, right? So if you have a normotensive patient who is going into hypertension, so the basic definition remains that systolic blood pressure, a rise in systolic blood pressure by 30 and rise in diastolic blood pressure by 50 millimeter of mercury above the baseline. Okay, if our baseline is 110 only, so 30 plus goes 140 and 15 if it was only 70, so goes to 85. So what International Society of Hypertension says, that even if you have a woman whose blood pressure is 130 by 85, you label her as having hypertension and you start antihypertensives. Okay, agreed? The evidence is World Justice Organization, FOXY, ICOG, GCPR, every organization they mention that you should start antihypertensives with 140 by 90 millimeter of mercury. Is that clear? So don't get scared. All our organizations, they are supporting what, in fact, they are guiding us that we should start antihypertensives with 149.
Many times, patient comes on the second day or third day, and she has her BP 110, 70, 110, 80 after taking antihypertensive. What should we do at that time?
But then if she is symptomatic, then only there is a problem, no? Why are you worried? 110, 70 or 120, 80 is not hypertension.
No. If she has come on the first day and her BP was 150 by 90 on that day, we started her on labetalol, and then on the very next day or next to next day she comes, or else she gets it checked at her own local doctors, and she finds it to be 110, 70. Then what we should do?
That is what I'm saying. Why are we worried about it? That because she's not having any symptoms of hypotension. She's not having giddiness or so. So it's not that she should not have 110, 70. You mean to say 140, 90 if you start the antihypertensive
and they keep telling us that we are not hypertensive, then why are we supposed to continue with the and they usually continue the
you have to tell her that because you're taking this tablet, your blood pressure has come down to normal. If you don't take this tablet, it will again rise. Okay, and damage your organ. So you have to counsel the patient. We don't have to, yes, okay. Don't fall prey to the patient because we have to face all these, catastrophes. Okay, so monitoring of diabetes, that was one. Now we come back to once again to insulin. I think Dr. Gaurav, silent for some time. We can have Dr. Gaurav. So insulin, when you start the patient on insulin, how you should monitor, whether you should hospitalize her, and then once you stabilize, how frequently you should monitor.
Yeah, so insulin, of course, if it's in the hospital, it is under the watch of, monitored by qualified people. So that would be more convenient. Of course, I also am attached to a teaching institute. So we have round the clock residents who monitor. We check the blood sugar level too early. And there are subcutaneous or, you do the insulin pens, which you can give at home. So that's another option for women, say, who stay far away or who find it inconvenient to come to the clinic.
But that is after you stabilize them, right?
Yeah. So for stabilization, it is of course better indoor.
Yes.
Under the watch, and you also have to check the fetal well-being during these times.
Yes. So for when you start the insulin, when the patient has very high sugars or maybe fluctuating sugar levels, it is recommended that very early morning pre-breakfast, that is fasting sugar, and then you have 3 meals. So 3 pre-meal and post-meal. Okay. So 3 meals, pre-meal and post-meal, and as Dr. Mudita said, that very late night, 2 a.m. blood sugar. Yes. So that is what is the 7 point of testing. So for all practical purposes, for Indian scenario, it is not possible, not feasible. Even if it is a very highly educated, rich family also, it is very difficult to counsel them, so many pricks and all. You may have that sensor monitoring, but that is later. When you are actually trying to stabilize, then we come up with the option that is 4 pointers testing. That means 1 fasting and 3 post-meal. Okay. So 4-point testing. So even in a day, if you monitor the blood sugar levels 4 times, that should also suffice. And once you stabilize the patient, then you can test the blood sugar levels every 3rd day. Okay, is that clear?
Okay, yes.
Panel, any difference of opinion here? from the panel? Any difference of opinion? Do we have the panelists here? Yes. Dr. Shikha, Dr. Sunita, I can see you all. Yeah. So I think we just go ahead with that. We have taken this patient successfully to near term. When do you want to deliver her? I will stop sharing now and just conclude this. Okay. We have lots of take home messages also, but then yes, Mudita. Dr. Shikha?
Yes, ma'am.
You want to deliver her?
Ma'am, actually, I would like to deliver her after 37 weeks, ma'am. Once 37 weeks are completed, or when she goes into labor.
Okay. Well,
If we are going for
if
elective
everything
surgery.
is fine, if everything is good, under control, maternal and fetal condition is good, still 37?
So, ma'am,
This
if maternal and fetal conditions are good, then we'll wait till term, ma'am. We'll wait till term, and it will depend if she's having what is the weight of the baby.
Large baby.
Ma'am, if it is a macrosomic baby of 4.5 kgs or more than 4 kgs
That
in
is
female,
planned cesarean section.
then
Okay.
it is a planned Caesar, ma'am.
Mhm.
And it's 37 completed with 38 weeks or 39 weeks. And if the weight is less, then we'll wait for normal labor, ma'am. If she can.
But then they say, see,
normally,
how they
ma'am.
do it, if it is a large macrosomic baby, you go for elective cesarean section. If it is an average size baby, the mother and fetal conditions are stable, wait till 39 weeks and then you induce and see for normal labor and delivery. Okay. Right? So if it is, you don't wait for 40 weeks here for diabetic women because they say that there are sudden unexplained stillbirths as well. Okay. So we skip all this, postpartum punishment and everything. So with this, I think Raj again, yeah.
Best wishes, ma'am. All the best for the election.
Best wishes, ma'am.
Thank
Yeah,
you so much.
please vote
It
for me
was
also.
just an humble, I think, yeah, mute yourself. So it is just a humble request and appeal to all of you that I'm your candidate for Vice President Foxy from West Zone. And I request all of you to please vote for me and support my candidature. The elections are in August, 1st to 10th August. So first of all, I request all the president and secretaries to please nominate me and then of course vote for me. So with this, I thank all of you and I thank all the panelists. In spite of being so busy, they joined and actually contributed to this panel discussion. So I'm very happy and thankful to all of you. I'm thankful to the entire Amogs and Amogs, of course, my own organization. I'm thankful to the president and secretaries of Ratlam, Rewa, and also Ujjain and Narmadapuram and Gwalior. And I'm thankful to all the panelists, chairperson, and everybody. I'm very happy that Dr. Braj and Dolly has coordinated the program very nicely. And of course, Dr. Dipti, your cooperation is very valuable. So over to you, Dr. Dipti, for your words.
Yeah, just 2 minutes. Just
Yes,
requesting
yes.
everyone.
Best wishes to Dr. Gaurav also. And
Yeah,
yes,
I'm
Gaurav, yeah.
standing for endoscopy committee after many years of service to Foxy. I was the assistant secretary of the journal for last 4 years. So please do tell your societies to nominate and vote, as madam said.
Requesting just a
best, Dr.
moment
Gaurav.
from my side also. I will be contesting for Environmental Health Committee and I need nominations from my own societies. Thank you, Dr. Sneha, for making me part of this. It was wonderful webinar with so many take-home messages. Over to you, dear Dipti, for vote of thanks.
Thank you so much, ma'am. I think expressing gratitude is the most important part of any program. And this quote probably applies to both a parturient mother and the obstetrician as well. Being a mother is learning about strengths you didn't know you had and dealing with fears you didn't know existed. And extremely grateful to Sneha ma'am and Brijbala ma'am for this fabulous webinar. It was a deja vu, with all the high-risk patients that we see at our tertiary institute as well. I would like to formally express our gratitude to Amogs President, respected Kiran Kottakoti sir, Secretary General, respected Bipin Pandit sir, immediate past President, respected Rajendra Pardeshi sir, Treasurer Amogs, Dr. Madhuri madam, National Coordinator and ICOG Chairperson elect, respected Parag Biniwale sir, our esteemed guests for the evening, Padma Shri, respected Leela Joshi madam, Professor Dr. Jyoti Bindal madam, Professor Dr. Kavita Singh madam, and Dr. Archana Baser madam for their kind words of wisdom. I am sure with continued academic efforts, we all would walk in the same direction and be able to bring down the maternal mortality. Our esteemed speakers, Geeta Balsarkar madam and Pushpa Somvanshi madam, our beloved chairpersons, respected Pam Sao ma'am, Dr. Shefali Shah ma'am, Dr. Rekha Singhal ma'am, and Dr. Mona Gupta ma'am, our learned panelists, Dr. Gaurav Desai, best wishes to you, sir, Dr. Sunita Vadhwani ma'am, Dr. Mudita Talsera, Dr. Varsha Khandelwal ma'am, Dr. Neha Saraf, and Dr. Shikha Khandelwal ma'am. And last but not the least, the Power Packed women. Best wishes to both of you, ma'am, Sneha Bhuyar ma'am and Brijwala ma'am. I am sure it is going to be hands down success for both of you. The amount of effort that you've been putting in, and the tech team for a seamless execution. And last but not the least, I am also contesting for the post of Chairperson Quiz Committee, and I seek your support and blessings for the same. And I hope that I would get an opportunity to serve the organization and represent Jabalpur at national level. Thank you so much, everyone.
Best wishes to you as well, Dipti.
Thank you, ma'am.
Thank you so much.
Yeah.
Thank you so much. Thank you,
Thank you,
everyone.
thank you, thanks, ma'am.
Thank you.
Best wishes, Deepti,
Thank
Dr.
you, ma'am.
Gaurav.
Yeah.
See you soon in some webinar or conference.
Yeah,
Yes,
sure.
ma'am.
Thank you so much, dear Sneha, for all your dedication, efforts for making it possible. Thank you so much.
Thank you, dear. Thank
Bye
you so
bye.
much. Chalo, bye-bye. Thank you,
Bye.
Mudita.
Good night, madam. Good night.
Good night. Good night, Gaurav.